with the discussion on fibrodysplasia ossificans and ossificans progressiva, which is a rare disorder of heterotopic ossification. So we know fibrodysplasia ossificans progressiva. It is also known as Munch-Meyer disease or myositis ossificans progressiva. It is extremely uncommon genetic disorder wherein the connective tissues like skeletal muscle, tendon, ligament, and fascia progressively transform into bone, forming abnormal secondary skeleton, which severely disable the patients. Its prevalence is around 1 in 2 million worldwide, and it doesn't have any genetic predisposition, ethnic or geographical prediction. So why it occurs? It occurs due to activating mutation of the activin receptor 1, activin-like kinase 2 gene that lead to increased bone morphogenic proteins, and it stimulates the osteoblastic activity. So this mutation causes connective tissue to heterotopically ossify following any minor or major trauma. And the patient appears normal at the birth, and except for the classical congenital and malformation of the great toes. During the first decade of life, the minor traumas lead to inflammation and painful swellings that resolve spontaneously. But later on, during the later phases of disease, the inflammation lead to activation of the bone formation, and this lead to soft tissue ossifications in the and ossification in the tendon, ligament, fascia into the bone. If heterotopic ossification involve the muscle that bridge the joint, it lead to the decrease in the range of motion of that joint, and the joint is involved secondarily due to disuse and inflammation. So the heterotopic ossification progress in the centrifugal manner from the axial to the appendicular skeleton, and this lead to ossification of bones, ossification of muscles, tendons, and ligament leads to formation of sheet-like or ribbon-like and rope-like bone, heterotopic bone that covers the body like an armament, and this lead to immobility of patient. So mostly the patients are become wheelchair bound in the third decade of life, and the survival is maximum up to 40 years. And the patients usually develop severe malnutrition due to ankylosis of TM joint, or due to respiratory cardiovascular or respiratory failure due to thoracic insufficiency syndrome. So diagnosis is basically clinical with the characteristic grade 2 deformities and progressive heterotopic ossification. Family history is rarely positive. The diagnosis can be supported by the genetic testing that can confirm the mutation in the ACVR gene. So let's discuss our case. Our case was a 12-year-old male who presented with who was apparently well 2 years back, and then he started to develop a painful swelling first noticed in the back of neck, which the treatment was taken, but the swelling didn't resolve. And later on, he developed another swelling on the back, and that progresses in the hardness, and that lead to immobility of cervical spine and decreased mobility of cervical spine. Later on, after 6 months, he developed swelling over the wrist also that progressively increased over the next 3 to 4 months, and that lead to restricted mobility of wrist joint. Then in next few months, he developed multiple bony swellings that lead to progressive joint immobility, and that ultimately leads to complete restriction in the movement of most of joints, including wrist, ankle, knee, spine, and TM joint over the next 2 years, making him bedridden from the last 6 months. So on examination, he has bony swellings bridging the joints, causing restriction in mobility of all the limbs as well as jaw, which lead to impaired mouth opening, and the patient was unable to eat solid food, and he take only semi-solid or liquid food. So he has weight loss and generalized malnutrition. He was born at term and had uncomplicated vaginal delivery. There was no family history of such type of illness, and milestone were normal. There was no significant past history. He was well oriented, conscious, and vitals were normal, and he has severe muscle wasting and malnutrition. And on examination, he has flexion deformities of the joints and the decreased movements. His mouth opening was only 2 to 3 mm. He has multiple forms of cutaneous bony lesions over the thoracic spine's back, signifying the ectopic bone formation. He has bilateral hallux valgus deformities. So this is the classical hallux valgus deformities that can be seen in such type of patient. And this is the picture of back of patient which is showing the ossifications, multiple bony swellings, and also this can be seen that there are bridges, ribbon like bony swelling in the back. He has bed sores, as we can see, because of immobilization, and he's completely bedridden. So his biochemical investigations were all normal. On CT neck there was a bone that can be seen bridging the TM joint, and on spine also we can see this is the heterotopic bone that is formed in a ribbon-like manner, causing immobility of spine. This can also clearly seen in the this CT image. And in pelvis also, there we can see the ligamental ossification. Paraspinal muscle are also ossified. In X-ray also they are visible. That it is visible that iliopsoas muscle is ossified. So this is also CT window showing the ossification in the paravertebral soft tissue and the adjoining spinous process that leads to decrease in the mobility. In the thigh also we can see there is multiple heterotopic bone formation is there. So how to manage these patients? Though after these clinical features of classical toe deformity and this radiology finding, we made the diagnosis of fibro dysplasia ossificans progressiva, and the sporting therapy was initiated, including the prevention of bed sores and nutrition therapy and analgesics for the pain management. Hager mouth opening gag was used to open the mouth slowly, and so that patient can have feeding started from the mouth, and the counseling was done. The main treatment is conservative only, and so how we diagnose this rare case? It is basically inherited in an autosomal dominant manner, but sporadic cases are also reported as seen in our patient. And diagnosis is mainly clinical with the characteristic extra skeletal ossification, grade 2 malformation, joint immobilization. The characteristic feature is the toe deformity, and the radiology supports the clinical diagnosis. So we should differentiate it from other causes of heterotopic ossification, especially traumatic heterotopic ossification and progressive osseous heteroplasia. So how we can differentiate between these two entities? The traumatic heterotopic ossification is basically the ossification occurring at the site of injuries, especially the spinal surgery and hip surgery, after spinal and hip surgery. So there is history of specific inciting event is there in these cases, and the ossification is localized to that point only, and it is non-progressive. While the progressive osseous heteroplasia can be differentiated from FOP in that manner that the ossification is basically mainly in the skin, that start mainly in the skin, while the cutaneous ossification is not there in the FOP. And the mutation, we can do genetic workup to check the mutation, and GNAS mutation is there in the progressive osseous heteroplasia, and there are no pre-osseous tumor like inflammatory flare up in this entity, and the characteristic skeletal deformity can be there like short stitches, round faces, and short fourth metatarsal in this, while in the FOP the characteristic deformity is grade 2 malformation. Other causes of heterotopic calcification are pseudo hypopara and tumoral calcinosis, and also in CKD we can see the heterotopic calcification, and but the biochemically we can found abnormalities like hyperphosphatemia in these conditions. There can be raised creatinine in CKD. So the characteristic radiological feature of tumoral calcinosis can also be found. So the in juvenile fibromatosis there are fibrous lesion but they don't ossify. So we can clearly differentiate from these two entities. Management of FOP is usually supportive, but with the physiotherapy and the anti-inflammatory medicines, and the genetic counseling is also needed, while the some new drugs have come up to manage disease, this disease, like mast cell stabilizer, chromoline, have been found to have some role in the decreasing the progression of disease, but still it is in the trial. Also, the activin A blocking antibodies, that is Geretosmab, is in the phase 2 trial, and it has shown good result, and it lead to decrease in the newborn formation. However, the bone that has already been formed has not been shown to improve with any of these treatment. Another new drug that has been recently approved for the treatment of this rare entity is palvarotene, and it is a selective retinoic acid receptor alpha RAR gamma agonist, and it decreases the newborn formation. The MOVE trial, that is the phase 3 trial, has shown that there is 62% reduction in the mean annualized new heterotopic ossification volume in the participant who has received the palvarotene, and but it doesn't resolve already the bone that has formed. So that treatment regime is basically the chronic daily treatment of 5 mg goes on, and during the flare up the 20 mg is given for 4 weeks, and followed by 10 mg for 8 weeks. So it is approved by FDA recently for the children, female age more than 8 years and male age more than 10 years. Side effects are like other retinoic acid receptor agonist. It can cause dryness, dry skin, dry lips, on dry eyes. It can lead to skin exfoliation, alopecia, erythema, etc. So that can be locally managed with the emollients. And the other side effect can be premature epiphyseal closure, and of course it's not safe in the pregnancy. So, but it has not yet approval from still European Commission. It is still pending. So take home points are: the clinical presentation of heterotopic ossification can be similar across the different etiologies. Key differences like trigger event, location of bone formation, progression, and associated condition help to differentiate them. FOP is rare cause of heterotopic ossification with the characteristic features like heterotopic ossification and grade 2 malformation. As the early clinical suspicion and diagnosis may halt the disease progression by preventing the minor as well as major trauma. So, new drugs can also be used wherever we have opportunity to get them, but they decrease the formation of uh, another new bones. And later in the course of disease, only conservative management can be given to the patient, and management strategies can be tailored according to the individual need of different patients. So I would like to thank the organizers for giving me opportunity and the patient hearing.
Much for invitation, and my talk will be about children with appropriate for gestational age versus children which were term and preterm as intrauterine growth restriction. And I would like to talk about assessment of insulin resistance in those group. How can I go to the next one? So, what the SGA? SGA means impairment of intrauterine fetal growth, most often leading to birth with insufficient weight, lower than -2 SDS, with reference to standards for given gestational age and sex. It's mean SGA. AGA, that's the children which were born preterm with normal weight for a given gestational age, appropriate for gestational age. Results of a study conducted between 2004 and 2007 in the group of 118 Polish children born with SGA confirmed scientific reports as the risk of insulin resistance, and we would like to present you the result concerning the carbohydrate metabolism in those group. So the aim of our study was to compare those carbohydrate metabolism parameters in the group of AGA preterm children with SGA preterm and SGA term, as well as with AGA term children. That's what we the number of children which were qualified. That was almost 90 children at the age of 7 and between 6 and 7 years. And in the group A, that was the group AGA, preterm children, 26 children were in group B, SGA, preterm children, 30 children at group C, SGA term, and 11 children at the group D, AGA term children. Group A, AGA preterm, that were children born at 33, almost 34 weeks of gestation with a weight of almost 2,000 grams, 1,973.6 exactly. That was minus 0.76 SDS. So as you see, that was not the definition of SGA. SGA, as I said before, SGA in group B, that were children born at 30, almost 3 weeks of gestation with a weight of 1,300 grams. So it was exactly minus 3.26 SDA. So the definition of SGA was exactly in that children. And group C, SGA term, children born at 39 weeks of gestation with a weight of 2,000, almost 2,300 grams. So it is minus 3.8 SDS, also SGA, but term. And the group C, AGA term children born at 38 weeks of gestation with a weight of 3,300 grams almost. So it was in normal children, only minus 0.25 SDS. The value of BMI SDS in those group was absolutely comparable. So group A was minus 1.2, group B minus 1.7, minus group C minus 1.4, and group D minus 1.4. So SGA there was no catch-up growth. It means that all of the groups didn't have any growth impairment, any growth deficiency. And at the table, you can see also the same information. So the age was between 6 and 7 years. Group A 6, B, C, and D 7 years old, and the number, as you see, 22 children in group A, 26 in SGA preterm, 30 children in at SGA term children, and 11 at AGA term. And gestational age, as you see, AGA and SGA preterm, 34 weeks and 33 for SGA preterm. And in group SGA term and AGA term, the gestational was normal. So 40, 39 and 30, almost the same, 39 in AGA term. And the latest is the weight. The weight for AGA preterm was 1,973, and for SGA preterm was 1,300, so minus 0.76 and minus 3.26. So you have here the definition of SGA. And concerning SGA term, the gestation, the birth weight was 2,300 almost, so it was minus 3.8 SDS, and AGA term had 3,000 to almost 300 grams, so minus 0.25 SDS, so it was normal children. What we would like to see, what we would like to estimate concerning the carbohydrate metabolism. So we want to see the fasting glucose and insulin levels. We wanted to see also the insulin resistance. And this is so HOMA and quickie HOMA, that's the insulin resistance assessment, and quickie that was the quantitative insulin check index. And also we wanted to see the lipid profile, so the cholesterol, triglyceride, LDL, HDL.
Next slide, please.
Yes.
Please go ahead.
Yeah. Yeah. So what was our results? As you see, the most important and the most interesting things were between SGA term and AGA preterm group. So insulin levels were significantly higher in the group of SGA term, its group, as compared with AGA preterm. So group C versus A, as you see the insulin level at the group C SGA term was 6 point almost 7 microunit versus almost 4, 3.60. So it was significant important. As you see, P was 0.000. It was very important. So the group SGA term, where the group was absolutely insulin resistance, comparing with AGA preterm, it was really, really important. And in the group, the same situation was in the group B versus A, where SGA preterm had the insulin 5.5, and AGA preterm group has 3.68, 3.7 microunit, and that was also statistical important. So as you see, the insulin level was higher in C and B group. So it's been SGA term and SGA preterm children. Concerning HOMA, insulin resistance index, HOMA was significantly higher in SGA term children as compared with AGA versus E. HOMA in SGA term was 1.38, and concerning the AGA preterm 0.73. So P, as you see, was really important, 0.0014. And the same was between SGA preterm in comparison with AGA preterm, group B versus A, 1.1 versus 0.73. So P, it was really below 0.5. The same concern index were lower in SGA term versus AGA preterm, 0.7 versus 0.96. So we didn't observe any insulin resistance and insulin sensitivity in group AGA preterm as compared with AGA term. So in group A versus D, as you see, HOMA was 0.7 versus 1.1, and Quickie 0.94 versus 0.8. So that was any differences, and that was an insulin resistance signs in the AGA group. So concerning the cholesterol concentration, the total cholesterol concentration was significantly higher in SGA C versus B. As you see, 175.5 versus 159 milligram per deciliter. And LDL level, sorry, were significantly higher in SGA term children. Compare with SGA preterm, C versus B, as you see, was also significantly increase in group SGA term. And we didn't observe any difference in BMI SDAs between all groups. And the results are in three tables. So as you see once again, the difference between insulin was between group C and AGA preterm and SGA term. And as you see, the insulin was significantly higher in SGA term, as well as HOMA insulin resistant, as well in insulin sensitivity index were lower in SGA term in group C. All the rest was not significantly important. And the same concerning the group A and B. So you can see AGA preterm and sorry, yeah. Here we can see the group B and C, so SGA preterm and SGA term. And as you see, the difference between the cholesterol and between LDL. So as you see, SGA term was significantly higher than SGA preterm, and the same concerning LDL was higher in SGA term concerning the SGA preterm. And the conclusion of our yeah, and let's talk about the conclusion. That's what we can say concerning those comparing of all of those four groups. We can say that the risk of insulin resistance appears to be more associated with lower birth weight than time of birth. Okay, so it was much more important in birth weight concerning SGA than time of birth, and no greater risk of insulin resistance has been established in AGA preterm birth. So it's the difference concerning all the papers scientific where we can find that AGA preterm can also, children of course, can also have the insulin resistance problem comparing to SGA term or preterm children, and we didn't agree with that concerning of our material. Thank you so much for attention.
Good evening to one and all present here. My name is Dr. Hita Bhankaria. My topic for the study was nutrient diversity in type 2 diabetes mellitus subjects in urban Indian population. As per the ICMR data that was published in 2023, the prevalence of the study stated that there are approximately 100 million diabetic patients in India, and the number increasing to 134.23 million by 2045. So what exactly is diabetes? Diabetes is a condition which is a serious disease where either the body is unable to make enough insulin or the body is unable to utilize enough insulin, and therefore there is an increase in the blood sugar levels. What happens is that when we ingest food in our body, we it is turned into glucose. The glucose is taken up by the cells, and ma'am, actually my camera is on, but it's not showing on the screen. 1 minute, I'll just try to do it again. It's showing blank, ma'am. Should I connect again?
No, you can go ahead. We are already ahead of time.
Ma'am, I can reconnect again once to see if it's working.
Dear Dr. Rita, there is no problem. You can go on with your presentation. It is not a problem.
Okay, ma'am. Okay, okay. Yes. So what happens is when we ingest food, the blood takes glucose into the cells with the help of insulin. However, when the body is unable to produce adequate amount of insulin in the body or utilize the insulin that is already existing in the body, the levels of the glucose in the blood rises. Either this case could be either a pre-diabetic case or a diabetic case. So there are different types of diabetes: type 1, type 2, pre-diabetes, gestational diabetes, and maturity onset diabetes of the young. Symptoms of diabetes are increased thirst, slow healing cuts and sores, fatigue, blurred vision, frequent urination, unexplained weight loss. The risk factors of diabetes vary depending on whether they are type 1, type 2, or GDM. Type 1 is directly linked to genetic, environmental factors, auto antibodies, or age related. However, type 2 diabetes is linked to obesity, age of more than 40 years, history of GDM, racial factors, sedentary lifestyle, increase intake of junk food, high cholesterol or lipid profile levels, pre-diabetic state, smoking, alcohol, insufficient sleep, high blood pressure, and mental disorders. Risk of GDM is when either the woman has a history of GDM in the previous pregnancy, or the birth weight of the child is more than 4 kgs. Either the woman is overweight and obese during pregnancy, or strong family history of type 2 diabetes, and or history of PCOS. There are other complications of diabetes are CVD, neuropathy, retinopathy, nephropathy, sexual dysfunction, foot damage, infection, dental problems, hearing issues, Alzheimer's disease, mental health issues, and acute complications are diabetic ketoacidosis and hypoglycemia, which could be life-threatening. So the causes of diabetes are insulin resistance. It could be an autoimmune disease, a hormonal imbalance, other hormonal related issues like Cushing syndrome or acromegaly, pancreatic damage, or genetic mutation. The cutoffs for diabetes in normal levels are any random is below 200 mg per dl, fasting is 100 mg per dl, and postprandial is anything below 140 mg per dl. However, anything above this could be pre-diabetic or diabetic. The treatment for diabetes is inclusion of glycemic index and glycemic load foods, carbohydrate counting, physical activity and diabetes management, insulin therapy, oral hypoglycemic drugs. Glycemic index is of food rich in carbohydrate provides an estimation of how quickly carbohydrates break down during digestion and how rapidly they are absorbed into the bloodstream. The term low glycemic integrates the GI of the food or the diet, the amount of carbohydrates in a given quantity of food, meal, or diet. So these are the cutoff values for glycemic index and glycemic load. The concept of glycemic index was started in 1980 by Jenkin, which was introduced, who introduced the concept stating that carbohydrates have an instant impact on the blood glucose levels. Glycemic index originally was designed for patients with diabetes as well as food selection guide to select low GI foods. One of the major risk factors linked to diabetes and metabolic syndrome is obesity. It was observed that Indians were at a greater risk of dyslipidemia and low HDL levels as compared to Caucasians. We also need to look into the visceral obesity, which is directly linked to non-communicable diseases like insulin resistance, diabetes, and CVD when compared to general obesity. GI and GL of foods also affect the storage and impact the GL of glucose response as well as the demand for insulin by the body by each serving of the food. Dietary fiber plays an important role in reducing the rate of carbohydrate entry from the gut and into the entire system. GI not only influences the rate of glucose from the plasma but also the absorption of glucose from carbohydrates. Carbohydrates react differently at fasting or 2 hours postprandial. Here, the key is portion control, which has shown a positive impact on postprandial levels of patients with type 2 diabetes. We need to have a larger data on the metabolic effect of low GI and high GI foods, especially with staple foods eaten in India to manage blood sugar levels before and after meals. The rationale of the study was to understand and evaluate the meals of importance of glycemic index and glycemic load. GI and GL have shown to have health benefits. Using GI while meal planning improves diabetic control, but also has an impact on other health parameters. Although these did not include the total carbohydrate intake of the meal, that is GL of the meal. There is very little data on similar studies that have been done in the city of Mumbai or in India, and therefore this topic was selected. The aim of the study aimed to find an association with GI and GL with nutrients in diet of diabetic male and female subjects in urban Indian population. The objective of the study was to identify and recruit 240 diabetic patients, both male and female, to assess their daily dietary requirement, find a correlation between glycemic index and glycemic load in both male and female subjects, to get urban Indian database on the regional dietary intake and GI and GL of males. The hypothesis was the GI and GL of Indian meals is high, which could be one of the reasons for the occurrence of diabetes. Methodology used was the data collection was done at Guru Nanak Hospital and Dr. Panikar's clinic. With ethics committee approval taken, the subjects were then voluntarily participated in the study and were explained the consent form in their local language. 240 subjects were taken, of which 99 were male and 141 were female, wherein their demographic, anthropometric, diagnostic, and biophysiological characteristics and dietary assessment was taken with purposive sampling. Going into results and discussion, here it was the mean age and standard deviation of the subjects. The mean age of the male subjects in the study was 48.78 years and females was 48.81 years. The number of pre-diabetics was very small and therefore there was no statistical significance seen, and hence both the groups were clubbed together. Most of the study population fell between the range of 41 to 50 years of male subjects and women between 51 to 60 years. It was observed that the monthly income of male subjects was 30,000 or higher, whereas females reported a monthly income of between 15 to 30,000 rupees per month. Most of the population of the study was comprised of Hindus and Muslims. The number of meals per day observed in both male and female subjects was only 4 major meals per day. However, we recommend that they should be taking small frequent meals throughout the day, but it was also observed that there were long gaps in between. Both male and female subjects showed sedentary lifestyle. Addiction patterns were observed in males, like chewing tobacco alcohol smoking consumption, which was higher in males as compared to females. The anthropometric data showed that the BMI of the study population was falling under both obese and overweight. The average BMI of male subjects was 26.82 and females was 29.21, which was falling under grade 1 obesity, and 21.21% of male subjects and 33.33% of female subjects were under grade 2 obesity. These were their biophysiological parameters, and it was observed that this fluctuation was due to eating pattern and sedentary lifestyle. Long gaps between meals were also seen amongst the subjects when their 3-day dietary recall was taken. The major consumption of their food pattern was bread, bakery, and fried food. All the calculations were done using the Diet Cal V10 software created by Dr. Gurdeep Kaur, AIMS, Delhi. In the current study, all the macronutrients were within the range, although the concern here was affected by poor quality of carbohydrates, fats, and proteins. Most of their diet was refined carbohydrates in the form of bread, pav, fried fish or mutton, mendu vada, vada pav, or samosa pav as their breakfast options. The micronutrient intake in the diet was also very low, which was directly correlated to the dietary pattern of the patients, followed with low complex carbohydrate food, which is low in complex carbohydrate, good quality fat, and good proteins due to the cooking techniques that were operated at the household levels. Most of the families would have fried foods as a part of their meals. It was observed that the glycemic index and glycemic load of both the major meals was on the higher side. Their meals consisted mainly of rice or pav for dinner, and the amount of green leafy vegetable intake was relatively lesser in consumption. The GI and GL were calculated using the formula for dietary recall for all the subjects. On an average, 50 to 100 grams of refined carbohydrate was consumed by the patients when the recall was calculated. This is just the formula of glycemic index and glycemic load. The different consumption oil patterns that were observed, 37.50% of the people had sunflower oil, 15% preferred rotation of oils, and about 13.33% of the people use groundnut oil as a part of their daily consumption. So the Pearson's correlation method here shows the difference of the eating male patterns. At 5% level of significance, a correlation was seen between the GI of carbohydrates in lunch in male subjects. There was a significant correlation seen between the GI of lunch and dinner with the total carbohydrate intake, the p-value of 0.05, and total starch intake of p-value of 0.05 of their meals. The Pearson's correlation method for glycemic index of nutrients between meals in female subjects showed at the level of 1% of significance of GI of dinner showed negative correlation with carbohydrate intake in female subjects, indicating a diet low in total carbohydrates that may raise the GI levels. GI of lunch and total available carbohydrate intake at lunch and total starch intake at lunch, the soluble fiber intake at lunch were all positive, all of them showed positive correlation at 5% level of significance. At 5% level of significance, the GI also the GI of the dinner also showed a positive correlation with fiber, total fiber, soluble fiber, as well as zinc. The Pearson's correlation method of glycemic load amongst the male subjects, it was observed that the glycemic load of lunch with carbohydrate intake from lunch, the total available carbohydrate, and the total starch intake showed a positive correlation at 5% among the male subjects. Likewise, a positive significant correlation was observed with glycemic load of dinner and total available carbohydrate, total starch at 5% level of significance. Ma'am, 1 minute. I think I missed one slide. The GI, the glycemic load of females for breakfast showed a negative correlation at 5% level of significance with insoluble fiber, soluble fat, and 1% significance of iron intake. Although it was observed that the GL of lunch with total available carbohydrate intake and total starch intake, insoluble fiber intake, soluble fiber intake, respectively showed a positive correlation observed at 1% and 5% level of significance. Glycemic load of dinner showed a positive correlation with energy. The intake at 5% level of significance for total fiber intake, soluble fiber intake showed a positive correlation at 1% level of significance with total carbohydrate ingestion, total available carbohydrate ingestion, and total starch ingestion. The conclusion is that we trust that including GI values in the Asian countries will augment the use and application of GI in search as well as clinical practice by nutritionists across the globe. The current study indicates that dietary habits high in glycemic index and glycemic load are indicators for risk of diabetes and prediabetes in both genders. In the current study, the population consumed a high intake of carbohydrate in the diet. Therefore, their GI and GL levels in all the major meals were high. The limitation of the study was that it was conducted during the pandemic. Data collection was restricted and therefore fat analysis and weight circumferences were not taken. HbA1c levels were not measured as a part of their routine checkup because the patients did not comply to it, as it was not asked by the hospital as well as the doctor at the clinic. What I would like to emphasize here and conclude is that protein intake, emphasis on the protein intake of food, choosing complex carbohydrates, eating non-root vegetables, that is including green leafy vegetables as a part of the diet, limiting intake of fruits to 1 or 2 fruits per day, inclusion of nuts and oil seeds, limited use of oil, avoiding sugar and sugar-related food products, using the plate method to serve the food could be beneficial in this case. The typical Indian traditional thali had a diet diversity, nutrient diversity, balanced macro and micronutrients, dietary fiber, antioxidants, prebiotics, and probiotics were a part of every meal. The method of cooking and the meal composition improved the nutrient quality and bioavailability. Portion control of meals using small bowls and thalis promotes the growth and development. A mixed meal reduced the glycemic index, improved satiety, and everything was within the range that is required for the meal. Thank you so much.
Okay.
So, hello everyone. I'm Dr. Abrar Bedr, and I'm a chemical pathologist at Basra Medical College. Today, I'm very excited to present to you this study titled Pancreatic Stone Protein, Regenerating Protein as a Biochemical Marker for Prediction of Microvascular Complications of Type 2 Diabetes mellitus. I'll be discussing how this marker could potentially aid in early detection and interventions for patients at risk of these complications. And thank you all for joining, and I'm very happy to share my findings and insights with you. So to begin, in 2021, the International Diabetes Federation estimated that around 537 million people were diagnosed with diabetes. And this figure is expected to rise to 643 million by 2030 and to reach to 700 million by 2045. And this marks a projected increase of 46% over the coming decades. So one of the critical issues of type 2 diabetes is its microvascular complications. And the major microvascular complications include retinopathy, nephropathy, and neuropathy. The insidious nature of these complications makes early detection crucial. And so and many patients may not exhibit the symptoms, the noticeable symptoms for these complications unless significant damage has already occurred. So, as you know, the root cause of type 2 diabetes is peripheral insulin resistance. And as a compensation mechanism, the pancreatic beta cells will start to secrete extra insulin to compensate for this resistance. However, with time, this compensation fails and pancreatic beta cells will start to lose its function and its mass. Patients with type 2 diabetes experience increased beta cell apoptosis, while neither replication nor neogenesis of beta cell is affected, indicating that increased beta cell loss is mainly responsible for its decline and in mass. So this highlights the importance of finding a new markers for regeneration or even survival of these beta cells. And one such marker is pancreatic stone protein. So this is a 16-kilodalton binding protein, lectin binding protein, and it is secreted by the pancreas into the pancreatic juice, and it was found to have highly upregulated in acute and chronic pancreatitis. In addition, PSP regeneration protein was found to have a regenerative capacity. In previous studies, it was reported that beta cell undergoing apoptosis induce neighboring cells to express PSP regenerating protein gene, resulting in PSP regenerating protein secretion, thereby providing a cue to the microenvironment to regenerate. So the aim of the study was to analyze serum level of PSP regenerating protein in patients with type 2 diabetes mellitus and to determine their association with the biochemical parameters and microvascular complications of type 2 diabetes mellitus. So this is a case control study with 150 participants, all within the age range of 40 to 70 years. These 150 participants were divided into 3 groups. The first group will be the control group, consists of 50 participants. The second group will be type 2 diabetes patients without microvascular complications, also consists from 50 patients, and type 2 diabetes mellitus patients with microvascular complication constitute the third group. As for the exclusion criteria, we excluded patients with type 1 diabetes mellitus. We did not want we wanted to focus only on patients with type 2 diabetes mellitus and to try to eliminate any confounding factors that are unique for type 1 diabetes. Also, any patients with active infection, tumor, inflammatory disorders, hepatic disorders also will excluded from this study to not make these conditions affect or impact the level of PSP and affect the results. Also, pregnant ladies also will excluded from this study to eliminate any hormonal or metabolic factors from affecting the level of PSP. We collected the biochemical parameters like random blood glucose, HbA1c, lipid profile, urea, and creatinine, and also the serum level of PSP regenerating protein were measured by ELISA. As for the results, this is the baseline characteristics of the study subjects. As you can see, we have 3 groups. Like I said, there are multiple significant parameters in this table, particularly the BMI, the blood pressure, and also the duration of type 2 diabetes. All these were highly significant and elevated in patients with type 2 diabetes mellitus with microvascular complications compared to patients without microvascular complications and also compared to the control group. This is the biochemical parameters of the study population. And as you can see, there is a high level of PSP regenerating protein in patients with type 2 diabetes mellitus with microvascular complications as compared to the second group, which is without microvascular complications, and to the control group. And this difference is statistically significant. Also, there is also significant difference between these groups in random blood glucose, in HbA1c, the TG, and also the HDL cholesterol. So this is a box plot illustrating the level of PSP regenerating protein across the 3 study groups. Starting from the left, you can see the control group shows a very little amount of PSP regenerating protein. And moving on to the second group, which is diabetics without microvascular complications, there is a slight increase in PSP regenerating protein. However, it's not as high as the third group, which shows a dramatic increase in the level of PSP regenerating protein. This group involved the diabetics with microvascular complications. This scatter plot illustrating or examines the relationship, the correlation between PSP regenerating protein with type 2 diabetes mellitus duration. And as you can see, there is a positive correlation with the Spearman rank coefficient of 0.59, and this is a significant value or significant Spearman correlation coefficient. This means that whenever there is increase in the duration of type 2 diabetes, the level of PSP also tend to rise. This is another scatter plot that shows the correlation between PSP regenerating protein and HbA1c with a Spearman correlation coefficient of 0.572. It's also statistically significant. This means that whenever the patient has HbA1c, high HbA1c, which is an indication of a poor glycemic control, also this means that there is high PSP. This receiver operating characteristic curve examines the diagnostic performance between PSP regenerating protein and HbA1c for prediction of microvascular complication. As you can see here, the area under the curve for PSP shown in blue equals to 0.973, and this value is quite close to 1, which indicates a high diagnostic accuracy for PSP regenerating protein compared to the area under the curve of HbA1c, which is 0.78, shown here in green. This it's also significant, it's also high. However, the diagnostic accuracy of PSP regenerating protein for prediction of microvascular complications was higher. So, in conclusion, this study found that PSP regenerating protein levels are elevated in patients with type 2 diabetes, especially in those with microvascular complications. Thus, PSP regenerating protein might be a promising marker for prediction of microvascular complications in patients with type 2 diabetes. Further studies is needed to explore the role of PSP regenerating protein in larger cohorts of type 2 diabetic patients after stratification according to individual microvascular complications, and to better understand the exact role of PSP regenerating protein in type 2 diabetes mellitus progression.
My name is Dr. Amir Ali Dabhawi. I have a bachelor degree in dentistry and also master's degree in oral medicine, and currently working as a lecturer at Islamic University in Najaf College of Dentistry. Our topic for today is my previous study, which is entitled Evaluation of Peynig-Morse Syndrome and Salivary Chromogranin A in Major Depressive Disorder Patients. So, the definition, depression has many classifications. There are many types of depression, but we're going to mainly focus on major depressive disorder. For example, there are other types such as bipolar depression and psychotic depression. Major depressive disorder sometimes is called unipolar depression. So this is the type of depression we are studying in my previous study. So major depressive disorder is a non-homogeneous disease that affects 1 out of 5 persons at some point in their lifetime. So 1 out of 5 persons on this planet going to be affected at any age of his life, and is considered the leading cause of disability globally. The symptoms of major depressive disorder are associated with the structural and neurochemical impairments in the corticolimbic areas of the brain. The behavioral symptoms of depression include multiple emotional, motivational, cognitive, psychosocial, psychological domains, including anhedonia, aberrant reward association perception, and memory defects. There are many symptoms of depressions. Some patients might gain weight, or some patients might reduce in weight. And other symptoms include, for example, no longer enjoying activities they were previously enjoyed in their life, and also problems with the sleeping, interpreted sleeping, and so on. Regarding prevalence of major depressive disorder, although it varies greatly among nations, the global prevalence of major depressive disorder is roughly 6%, with a lifetime risk of depression of 15 to 18%. Major depressive disorder is common, with one episode arising in about 1 in 5 people, as we talked about. The prevalence of depression peaks in both genders in the second and third decades of their lives, so in their 20s and 30s, with subsequent more peak occurring in the fifth and sixth decade of life. Throughout a lifetime, depression is almost twice as common in women as in men. So we see women have, in general, gonna have twice as much, or the ratio of women is 2 to 1 regarding the men. Regarding stress biomarkers, so as we talked about, I'm gonna in our study we measured chromogranin A, salivary chromogranin A. So what is stress biomarkers or stress salivary biomarkers? So in response to stressful stimuli, there is a simultaneous activation of specific areas within the central and peripheral nervous system. The physiological reaction of nervous system to stress involve the stimulation of the hypothalamus and brainstem, as well as the activation of hypothalamic pituitary adrenal axis and the autonomic nervous system, which encompasses the efferent sympathetic adrenal medullary system. These systems work with the immune system and play a significant role in the development and progression of stress-induced diseases. Regarding chromogranin A is an acidic glycoprotein that is released from the sympathetic nerve endings and the adrenal medulla. It's actually released by neuroendocrine cells in these structures. According to earlier research, pigs under stress from isolation or immobilization had high concentrations of chromogranin A in their saliva. So as we know, we can take these biomarkers either from the blood or from the saliva. The saliva, regarding the blood, is more easy and more convenient for the patient. Numerous studies have suggested that salivary chromogranin A is a sensitive as well as promising salivary biomarker of psychosomatic stress in people. Regarding burning mouth syndrome, this is the second variable we measured in our study. Burning mouth syndrome is characterized by sensation of burning or dysphagia, as the mucosal appearance of the mouth appears normal. So we examined the patient. He complained from burning sensation, dysphagia. We examined the mouth. We see nothing. The mucosal appearance is normal. We have a hint here because they describe the pain as the whole mouth or the whole tongue. And this gives us a hint that there might be a psychological impact or effect on this condition. Multiple possible causative or precipitating factors of burning mouth syndrome have been suggested, including psychiatric disorder. In a case control study, Howe et al. In 2009 indicated that it is possible that the etiology of burning mouth syndrome has its beginning in psychological factors. Mental disorders like depression and anxiety play a critical role in the modulation of pain perception. This is due to their ability to influence individual pain perception through various mechanisms. For example, alteration of pain threshold influencing nerve transmission from the peripheral pain receptors and increasing or decreasing individual pain perception. And this is, by the way, similar to general arthralgia. So our aim of the study was, our study aimed to evaluate certain oral diseases such as chronic mouth syndrome in major depressive disorder patients, and also to study the levels of salivary biomarkers such as chromogranin A in major depressive disorder patients. Materials and method. Uh, our study was a cross-sectional study carried out at Al Hakim Hospital in Najaf City in Iraq and was authorized by the Ethical Committee of the College of Dentistry, Baghdad University, under project number 458-722. For inclusion and exclusion criteria, so to be included in this study, patients had of 18 years of age or older have to be diagnosed with depression by a specialized psychiatrist. Regarding exclusion criteria, it included patients who consulted for emergencies or unable to complete the self-questionnaire. Pregnant women also was to exclude other type of depression, and subjects or people on corticosteroid treatments, and patients who had a history of radio or chemotherapy. All patients were examined to detect any oral manifestations and also asked about Benign mouth syndrome. Regarding data collection, a total of 49 patients with major depressive disorder were included in the study. The control group consists of 34 healthy subjects with no signs and symptoms of systemic disease. The study group received a diagnosis in accordance with the 5th edition of Diagnostic and Statistical Manual of Mental Disorders, DSM-5, at Al Hakim's Hospital by psychiatrist specialist in Najaf City. Regarding sample collection, so we asked the patient to wash their mouth with pure water before the sampling. All participants were instructed to collect saliva in their mouths for 10 minutes without swallowing and to spit into a clean plastic container. This is also called unstimulated salivary flow rate. We also measured the unstimulated salivary flow rate, but it's in another paper. Regarding now, we come to the results and discussion. The study showed that the age range of patients with major depressive disorder was between 23 and 66 years. And for the control subject was 20 to 57. The mean age of major depressive disorder patients was 44.3 years with a standard deviation of plus minus 10.19 years. For the control group, the mean age was 41.26 years, and the standard deviation was plus minus 10.98 years, with no significant difference, as we see in this table. There was no significant difference between the two groups regarding the mean age. As the results for the Benign mouth syndrome, results showed that that for the study group there were 23, which is 46.9% of patients had Benign mouth syndrome, while 26, representing 53.1% patients of the study sample didn't have Benign mouth syndrome. This is for the study group, the major depressive disorder group. As for the control group, only 5, representing 14.7% of the control group individuals, reported to have Benign mouth syndrome, while 29, representing 85.3% individuals, didn't have Benign mouth syndrome. So as we see, there was a significant difference between the two groups regarding reporting of Benign mouth syndrome. Chronic pain and discomfort in the mouth are the hallmark of Benign mouth syndrome, a condition that lacks any visible lesion that would indicate its cause in a clinical setting. The pathogenesis of Benign mouth syndrome is multifactorial and elusive, and 85% of individuals with Benign mouth syndrome report having psychosocial comorbidities. In contrast to etiological initiating triggers, it's yet unknown if the psychological disorders are the result of having Benign Mouse syndrome, separate comorbidities, or modifiers of the Benign Mouse symptoms. The current study finding revealed a statistically significant rise in Benign Mouse syndrome in major depressive disorder patients compared to healthy volunteers. As a result, our findings suggested that Benign Mouse syndrome and psychological disorders are related, specifically depression. This study findings are consistent with those of earlier investigations. So there are many studies and earlier um, investigations that reported a connection between Benign Mouse syndrome and psychological disorders. Mental illnesses like depression and anxiety are crucial in the modulation of pain perception. So here might be the hint, the modulation of pain perception, because they alter individual pain perception by affecting the pain threshold, affecting nerve transmission from the peripheral nerve receptors, and increasing or decreasing individual pain perception. Regarding our results for the chromogranin A, salivary chromogranin A, and by the way, I didn't find any previous studies that measured this variable in a patient with major depressive disorder. So the mean and standard deviation of salivary chromogranin A was 31.46 plus minus 10.93 picogram per milliliter. The range was from 12 to 57 picogram per milliliter for patients in the study group. Well, for the control group, the mean and the standard deviation was 24.96 plus minus 7.16, and the range was 12 to 41.5 picogram per milliliter. So the result of the study showed that there was a significant difference of salivary chromogranin A levels between the study and control group, as the p-value was less than 0.05%, and that was using a t-test. So salivary chromogranin A was significantly higher in major depressive disorder patients than in control subjects, and we can see that in this table. The study also showed that there was no correlation between salivary chromogranin A and other parameters except for the gender. It was higher in males compared to females. Salivary chromogranin A is an acidic glycoprotein. Since then, it has been found to associate with catecholamines in the secretory granules of a variety of endocrine structures and neurons. It has been shown that chromogranin A is stored in submandibular glands granular convoluted tubule and released into the saliva in response to norepinephrine and acetylcholine stimulation. As a result, the submandibular gland releases salivary chromogranin A when stimulated. There are no reports on the level of salivary chromogranin A in people with depression or anxiety, despite previous research showing that the rapid and specific increase in chromogranin A in human saliva occurs in response to various stress factors. So stress factors is different, as you know, from depression and anxiety. The fact that salivary chromogranin A levels are not influenced by the time of the day is a significant benefit of this method of measurement. There are other salivary biomarkers such as cortisol, and we might think that it's, and actually it's proven, some studies might contraindicated that, but the most of the literature says that cortisol is rise in patients with depression. But cortisol, as you know, is a change as the time of day changes. But salivary chromogranin A is more standard, so it's much easier and better, in my opinion, at least, than salivary cortisol. No previous studies assessed salivary chromogranin A levels in major depressive disorder. It was found that there was a significant increase in salivary chromogranin A levels in subject under psychological stress. According to Matsumoto et al., women who were at their premenstrual period exhibiting cluster of extremely distressing negative emotional symptoms had significantly higher salivary chromogranin A levels in the late luteal phase. So this was the only study I found about chromogranin A previously regarding this psychological stress. Conclusions. But of course, you know, it's different than major depressive disorder. Conclusions. In conclusion, we found that major depressive disorder patients have much higher incidence of reporting panic mouth syndrome, which indicate the importance of psychological factors in this condition. And salivary chromogranin A is a good salivary biomarker for major depressive disorder. However, as you know, limitation of this study, we suggest more research to be done with larger sample size and with better standardization methods. The references for this presentation you can find by scanning.
Yes, doctor. My topic is that the role of the pro-inflammatory cytokine interferon gamma in type 2 diabetes and its correlation with atherosclerosis. Diabetes mellitus is a general term from a group of metabolic disorder with the major feature of chronic hyperglycemia. It's a result of the either impaired insulin secretion or impaired insulin efficiency, or most often both. Type 2 diabetes is deficiency due to pancreatic B cell disinfection and insulin resistance in a target organism. As we know, the atherosclerosis is the most complication associated with type 2 diabetes mellitus. It's atherosclerosis is a disease which plaque is built up in arteries that's made of fat, maybe cholesterol or other blood substance. Elevated triglyceride level of the inflammatory response occur during the atherosclerosis to the progression of the disease, as we show in the drawing in the slide. In atherosclerosis, we usually consider the chronic inflammation disease. The inflammation plays an important role in all stages of atherosclerosis. Interferon gamma as inflammatory cytokine involved in innate and adaptive and adaptive or can you hear me, doctors?
Yes.
Okay.
Dr. Marva, we can't be able to hear you. Hello, Dr. Marva. Dr. Marva, are you still in the meeting?
Instead, I'm sorry, it's a complication in my network.
Okay, is it okay if we can share your PPT on your behalf?
Just a minute, please. I'm with you now.
Okay, fine. You can proceed on with your present.
Okay. The aim of this study is determine whether of interferon gamma level and AIP in a patient with type 2 DM and associated with atherosclerosis development and the effect of interferon gamma concentration level in disease progression. The subject material and methods in this study was connected on 82 subjects. Results in this study show the analysis of 16 patients with established diagnosis of type 2 diabetes mellitus compared with 22 apparently healthy person. We divided this patient with a two group, a patient without dyslipidemia and a patient with lipidemia. And the lipidemia is during the 5 years. Material of method, we collect 10 ml blood and we collect during by disposable syringe by Van Bencher method from patient and control between 9 and 11 a.m. after 20 or to 40 fasting time. The blood was divided in 3 equipments, an EDT tube for testing the HbA1c and the fasting and lipid profile, and we centrifuge the plain tube to isolate the plasma serum collectory. The serum was divided in 3 Ebenroff and freezing to concentration the interferon gamma stimulation. Serum interferon gamma were quantitative determined by patient and control subject by means of a sandwich ELISA test using a commercially available kit. Fasting blood sugar and other parameters were determined by automatic biochemistry. Lipid profile determined by automatic biochemistry analysis. HbA1c by photo automated analyzer. This picture of my work in my ward by sandwich ELISA test. The result, we show in the table the mean diffusion and standard diffusion level between a parameter, age, duration, BMA. We know that not significant between the two groups. In this table, we see the parameter fasting and HbA1c. This significant, the p-value is significant. In this table, we see the parameter of AIP, RR1, RR2, cholesterol, triglyceride, VLDL, HDL, LDL. We see the significance either the cholesterol between the group. In this table, we see the interferon gamma was a significant by comparison with the 3 group. This table, we see the receiver operation curve analysis for the investigation parameter in type 2 DM patients with and without dyslipidemia. The parameter interferon gamma and AIP show a significance from to p value. This table shows the different parameter, and we show it's not significant to compare to interferon gamma. The conclusion of this paper was diabetes is associated with a dyslipidemia and atherogenic risk, as well as a rise in the inflammatory cytokine interferon gamma in stage of atherosclerosis. The type 2 DM without dyslipidemia, the initial period of atherosclerosis. The level of interferon gamma and the AIB may reflect the progression atherosclerosis, which may give an alarming sign. And if a purpose treatment is taken, we can prevent the process. Thank you for your listening.
hyperglycemia, which causes activation of different biochemical pathways that lead to increased hypoxia, reactive oxygen species formation, and release of various pro-inflammatory growth factors and cytokines. The oxidative stress in diabetes leads to pericyte loss, and this pericyte loss leads to basement membrane abnormalities. Increase in certain chemokines and angioprotein 2 lead to the increased leukocyte adhesion, which is known as leukostasis, rolling extravasation into the surrounding tissues, influx of monocytes into the retina, and increased production of cytokines, including the very important vascular endothelial growth factor, the VEGF, and other factors. The activation of macrophages serves to amplify cytokine production, enabling the activation of resident microglia, further fueling the pro-inflammatory environment. All these cytokines act on the endothelial cell junctions, resulting in breakdown of the blood-retinal barrier and increased retinal vascular permeability that leads to plasma leakage, which is the clinical manifestation of diabetic macular edema. Hypoxia and inflammation in diabetes leads to an angiogenic switch with increased angio2 levels. In a healthy vasculature, the inhibitory molecule angio1 binds to the receptor Tie2 necessary for the maintenance of and stability of the vasculature. In diabetes, however, angio2 levels increase, competitively inhibit angio1, and bind to Tie2 receptors. The binding of angio2 to Tie2 leads to increased vascular endothelial growth factor sensitivity, pericyte loss, and inflammation. Vascular endothelial growth factor leads to stimulation of microaneurysmal formations and the increase in vascular permeability with leakage of fluid into the retinal tissue. Classification of diabetic macular edema is divided into clinical classifications and investigative classifications. The clinical classifications are the historical ETDRS definition of clinically significant diabetic macular edema with thickening of 500 of the retina 500 microns from the fovea, hard exudates 500 microns from the fovea together with retinal thickening, or retinal thickening 1 disc diameter away from the fovea, but any part of it is 1 disc diameter from the fovea. The fluorescein angiographic classification includes focal diabetic maculopathy, including a localized area, diffused maculopathy, including a larger area of the macula, ischemic maculopathy, where there are areas of ischemia and non-perfusion of the vessels, and mixed maculopathy. Recently, OCT has been introduced to be the main line of classification and management of diabetic macular edema. Several classifications were introduced by the OCT, the first of which is the classification which divides the macular area into 9 ETDRS macular areas, and in these areas, the retinal thickness, the extension of the edema, the volume of the edema were evaluated, together with the morphology of the leakage present, whether it is a compact retinal thickening, cystoid thickening, or neuroepithelial detachment. In addition, the vitreoretinal relationships between the posterior vitreous face and the retina are evaluated with the evaluation of no disorganization of the retina from the posterior vitreous face to tangential traction to anteroposterior traction. A second classification describes fully the internal retinal pathologic changes and grades them, whether these changes are vitreoretinal relationships, disorganization of the inner retinal layers, retinal thickening, external limiting membrane and ellipsoid zone status, hyperreflective spots, intraretinal cystic spaces, serous retinal detachment are all evaluated. Another classification, which is the MFAS OCT classification, which divides the retina into two segments, an inner segment and an outer segment. Pieces of fluid in the outer segment, which is segment 2, around the photoreceptors, carries a worse visual prognosis. And this is an example of fluid in the inner part of the retina. This is an example of fluid involving both the inner and outer parts of the retina with a poorer visual prognosis. OCT angiography is a recent modality also for classification, and the presence of biomarkers in diabetic macular edema with OCTA is very important and particularly important in helping the treatment options and the follow-up of the cases. And these involve intercapillary spacing, the presence of foveal avascular zone disorganization, such as a larger foveal avascular zone, loss of asymmetry of the foveal avascular zone, non-perfused areas indicating ischemia, microaneurysms, intraretinal microvascular abnormalities are all evaluated. Also, the retinal vascular density is very important to know the extent of ischemia present in the retina. Systemic factors are also very important in the evaluation of the case, and it was found that control of diabetes, control of the level of serum cholesterol, control of proteinuria, and hypertension are all very important in decreasing the onset of diabetes and decreasing its progression. Other factors such as puberty and pregnancy, because mainly of the hormonal changes, exacerbate the diabetic retinopathy. The follow-up schedules for patients of diabetes are divided into two items. The first item, whether the onset of diabetes is before 30 years, and in this case, the recommended time for first eye examination is 5 years of the diagnosis, or more than 30 years of age at onset, where the recommended time for first eye examination is upon diagnosis. Yearly examination is then recommended. Prior to pregnancy, preconception or early within the first trimester is a very important follow-up examination, and then 3 monthly. Also, the examination depends upon the degree of the pathology present in the retina. The worse the pathology, the closer is the follow-up periods. Management of established diabetic macular edema includes first the laser treatment, focal or grid laser. Focal laser is used for focal non-center involving diabetic macular edema, and this reduces the risk of moderate visual acuity by 50% in eyes. And if the non-center involving diabetic macular edema is of the diffuse type, a grid laser is performed, and this was found to correlate with visual acuity stabilization in 75% of the eyes. Image-guided laser therapy, or the navigated laser therapy, is a new modality where the laser machine plans the laser spot placement. Laser treatment restores the integrity of the inner blood retinal barrier and the outer blood retinal barrier by stabilizing the endothelial cells and the retinal pigment epithelial cells. It also decreases the consumption of oxygen by the photoreceptors, decreasing the blood flow, and all these factors decrease the leakage. Micropulse laser is a new modality which avoids the death of the retinal pigment epithelial cells, enhancing its capacity to participate in the therapeutic response. There is no loss of functional retinal tissue and no inflammatory response, unlike the conventional laser. It is repeatable therapeutic modality and produces a very nice success rate. Anti-VEGFs have been introduced in the past 2 decades, and they are very important and a revolution in the management of diabetic macular edema. And there are certain OCT findings that predict a worse best corrected visual acuity in response of anti-VEGF therapy when these are found. And these include the central retinal thickness, the disorganization of the inner retinal layers, the ellipsoid zone disruption, the presence of large intraretinal cystic spaces, subretinal fluid in the subretinal space, and loss of the subfoveal ellipsoid zone and external limiting membrane. On treatment, we can predict the anti-VEGF response. After 3 anti-VEGF injections, if there is a gain of 10 letters or a decrease in the central retinal thickness by 20%, we expect a good long-term response to anti-VEGFs. Another way is that after 1 anti-VEGF injection, if central retinal thickness decreased by 15%, the central retinal thickness is expected to decrease by 25% by 3 months. Intravitreal steroids are another modality because all hallmarks of inflammation are seen in diabetic macular edema. 2 very important intravitreal steroid inserts are used: the ileuvine insert, which is fluocinolone, and the ozordex insert, which is dexamethasone. It was found by studies that dexamethasone has a less incidence of glaucoma and less incidence of cataract with its use. Therefore, it is the first choice of treatment. The ileuvine insert is therefore the second choice of treatment. And this is the inserter by which the insert is inserted into the vitreous cavity. The advantages of steroids that they are longer acting than most anti-VEGFs, therefore with a less social and financial burden on the patient. They are useful in cases not responsive or poorly responsive to anti-VEGFs, and they are a first choice in patients with a history of major cardiovascular event or cerebrovascular event within the previous 3 to 6 months, and in cases of breastfeeding and in pregnancy. Vitrectomy for diabetic macular edema is important in cases where there is anteroposterior traction to relieve the anteroposterior traction on the retina. And in the absence of anteroposterior traction, its role is controversial. However, the rationale is to eliminate chemical mediators such as VEGF in a premacular liquefied pocket. The algorithm for the management of diabetic macular edema, we do an OCT first, and we see if there is no vitreomacular traction or if there is vitreomacular traction. If there is no vitreomacular traction, we have 3 options. The first option is we find a subclinical diabetic macular edema where there is thickening of the center of the macula identified by OCT but not detected on clinical examination. This is managed by controlling the systemic factors and observation. In cases where there is non-center involving diabetic macular edema, laser treatment is the recommended line of treatment, whether this laser is a modified ETDRS treatment for the microaneurysms and the retinal thickening, or it is a focal treatment. In the presence of center involving diabetic macular edema, anti-VEGFs are the first line of choice unless contraindicated. If there is no response to anti-VEGFs, one can do one of 2 lines of treatment, either to shift to another anti-VEGF or to shift to steroids. In cases of pregnancy, diabetes mellitus, diabetic macular edema in pregnancy, we see if it is a clinically significant diabetic macular edema, micropulse laser is the safest. Grid or focal lasers are another modality. In refractory diabetic macular edema, dexamethasone implant is used. Anti-VEGFs and triamcinolone are better to be avoided during pregnancy for fear of teratogenicity. If the diabetic macular edema is mild or developing during pregnancy, observation is the choice since the edema may well resolve after delivery. Management of diabetic macular edema associated with proliferative diabetic retinopathy. If it is non-center involving, we do focal laser. If it is center involving, we inject anti-VEGFs, and after 2 weeks, we perform a PRP. Management of diabetic macular edema with positive vitreomacular traction. If the traction is anteroposterior, vitrectomy is indicated. If it is tangential, we can begin by anti-VEGFs, but if there is no response, we can shift to vitrectomy. Newer advances to solve the unmet needs in the management of diabetic macular edema include predictive medicine, which detects the occurrence of a disease before its manifestations appear in an individual based upon population-based cross-sectional studies. Second is to solve the problems of delayed diagnosis, referral, and screening by the advent of new non-mydriatic ultra-wide field fundus cameras, the use of handheld devices, and the use of artificial intelligence. Reducing the burden of monthly anti-VEGF injections is solved by the new port delivery system, which is implanted in the pars plana. It acts continuously for 6 months and is refillable on a clinic-based method. Newer pathway drugs are recently under investigation for the treatment of diabetic macular edema, overcoming the poor response to anti-VEGFs. You can see here the pathogenesis we said in the first slide of the presentation, and all these drugs are under trial. 2 important drugs are approved by the FDA, the faricimab, which is approved together with the angiotensin system inhibitors. Angiotensin system inhibitors, or the RAS inhibitors, we found that it was found that hyperglycemia causes an increased retinal production of renin-angiotensin system components, angiotensin 2 and its receptors type 1 and type 2. This leads to retinal leukostasis, AGE activation, and gene expression of VEGF. The 2 important drugs which were found to be useful in stopping this cycle are the lisinopril, which is an angiotensin converting enzyme inhibitor, and the candesartan, which is a RAS receptor blocker. Recently available drugs in the market are the faricimab, which is a very potent anti-VEGF drug, because it is not an anti-VEGF drug alone, but it also targets the angioprotein 2, which we said at the beginning of the lecture, that binds to Tie2, decreasing the stability of the vasculature. Brolucizumab is another drug which is recently introduced. It has a very small molecular structure. It is very effective in drying the retina, but it has a very serious adverse effect, which is a 3.3 incidence of vasculitis. Aflibercept is well known in the treatment of diabetic macular edema in the 2 milligram concentration. However, recently it has been introduced in the 8 milligram concentration, which allows a wider spacing of the injections, 12 to 16 weeks instead of 8 weeks with the 2 milligram concentration, with no increase in the incidence of adverse effects with the 8 milligram dose as compared to the 2 milligram dose.
Requires special attention, and we know about the negative impact of hyperglycemia during pregnancy on the development of the placenta and fetus. And there are also numerous studies have shown an association of anemia with various pregnancy complications, including impaired placental functioning and the development of fetal growth retardation syndrome. Here I have to note that previously no studies on the combined effects of GBM and anemia, including
Dr. Dinosa, your slides are not moving.
Of placenta have been conducted in the country, which determines the main prevalence of this work. We know that diabetes mellitus is one of the chronic conditions characterized by the presence of hyperglycemia to the impairment of insulin secretion, defective insulin or action or both. And we know there are different types of diabetes available, type 1, type 2, other types, and also here about gestational diabetes, which refers to the glucose intolerance with onset or first recognition during the pregnancy. And was our purpose of our study was to study the morphological and functional features of the placenta and perinatal outcomes in women with the gestational diabetes in combination with anemia. So what were the main objectives? The first one is to establish the frequency of medical and social characteristics of pregnant women with GDM combined with anemia. To study the course of pregnancy, childbirth, and condition of the fetus and newborn with mentioned extragenital diseases, and to study the morphological features of placenta and their relationship with the functional change in the woman with GDM combined with anemia. And the last point was to develop a set of measures to optimize the diagnosis and management of pregnant women with GDM combined with anemia, taking into account the characteristics of placental development. So here I have to note that the research was conducted at the Department of Obstetrics and Gynecology and Addis Ababa State Medical University. Placenta studies were conducted in the Department of Morphological Diagnostics of Tumors, the Scientific Republican Center of Oncology in the Republic of Tajikistan. And during the study, approximately 2,000 pregnant women were recruited, but only 1,737 pregnant women gave informed consent, and from them 76 patients were excluded due to the non-compliance with the key inclusion and exclusion criteria, and for 1,661 patients get oral glucose tolerance test. And from this group, we take into account 100 main group patients. And also we had a control group of 37 patients. And in data which we analyzed for 137 patients in total, the 38 patients were with gestational anemia, gestational diabetes in combination with anemia. So it's 5 with only gestational diabetes, 27 with only anemia of different degrees, and 37 the control group, which didn't have gestational diabetes and anemia. And in order to study and evaluate the features of morphological structure of placentas in each study group, we take 42 placentas in total, and they were statistically analyzed. And from this 13 placentas were from the combined group, 10 from the GDM group, 8 from anemia group, and 11 from the control group. So here, the main key inclusion criteria was also involved in the study. That was a patients with a pregnancy up to 28 weeks of gestation, and given written and verbal informed consent. Case of exclusion criteria that was present of type 1 or type 2 diabetes, acute inflammatory disease, presence of tumors, and untreatable thyroid disease or other endocrine diseases. So what was the main research methods that we had adopt questionnaire, performing oral glucose tolerance test, general clinical examination, ultrasound investigation of fetus and placenta in different gestational weeks, Dopplerography of fetus, biochemical examination, morphological examination of placenta, measuring glucose concentration in a newborn at 30 minutes, and statistical analysis. So, as shown in the figure, the frequency of GDM and anemia does not tend to decrease. Among the examined contingent group participants, GDM was detected in 36.5% of pregnant women anemia in 43.9%, and among the diagnosed pregnant women with GDM, anemia was present in 15.9% of women and in 31.1 red blood cell counts, and sugar concentration was within normal limits. At the time of the examination, the age of the pregnant women in study groups ranged from 18 to 40 years. When studying the average values of age, including height, in the compared group, there was no statistically significant difference. And the combination of gestational diabetes with anemia was most often observed in pregnant women aged 25 to 29 years. GDM and anemia of varying severity in pregnant women aged 20 to 24 years. Here and here. When studying the weight and body mass index of women at the time of registration, there was statistical difference in the compared groups. The proportion of pregnant women with normal body weight was significantly lower in the GDM group compared to the other groups. And the proportion of pregnant women with overweight and obesity was significantly higher in the GDM group. And GDM combined with anemia group. And overall, more than 85% of patients were housewives at the time of examination. The overwhelming majority of women whose pregnancy was complicated by GDM in combination with anemia were housewives living in urban areas. The material and living conditions of the patients were generally satisfactory and did not deserve special attention. An important role in the study was played a study of the relationship between family history and manifestation of non-infectious disease such as GDM. During the collection of anamnesis, the pregnant woman more often indicated the presence of diabetes and arterial hypertension, in particular from their parents or parents-in-law, as well as aunts and uncles on both sides. In general, the higher frequency of hypertension in family was found in the group of the subject with GDM combined with anemia than in other groups. GDM. And when we are studying the parity, the frequency of premenopausal women in all the studied groups was quite high. And especially observed in the group of pregnant women with anemia. And a reliable predominance of premenopausal women was noted in GDM group than in comparison group. And GDM combination with anemia was often found in multiparous women. Okay. Yeah. When we studied the association of the main factors, the macrosomia in previous pregnancies was found in a woman with the GDM and compared to the absence of the GDM. And cesarean section, preeclampsia, and gestational hypertension in the anamnesis were significantly more often observed in pregnant women with anemia compared to the patients without anemia. On average, the first visit of women at the time of registration was 13.2 weeks of pregnancy, but the average body weight was around 60 kilograms. The minimum weight was around 42 kilograms and maximum weight 99. The greatest weight gain was significantly higher in the GDM group combined with anemia than in other groups. Then we determine the concentration of glucose in the blood by performing the oral glucose tolerance test. At 24-28 weeks of pregnancy, the comparative analysis showed that the significantly greatest average increase in plasma glucose concentration on fasting level after 1 hour and 2 hours, and it was higher at the fasting level compared to the first and second hour, and it was higher in the group of the GTM compared to the other studied groups. The course of the pregnancy in the first trimester was significantly more often complicated by a threat of miscarriage, vomiting of pregnant women, and there was noted in every third subject in the GTM the anemia group among which is reliable prevalence with patients with preeclampsia compared with the comparison groups. And every 10th pregnant woman in anemia group had gestational hypertension in the GTM in combination with anemia, severe preeclampsia. And in order to study the state of fetal-placental complex, we performed Doppler ultrasound examination at 28 to 62 weeks of pregnancy in participants. And we did a Dopplerometry of umbilical artery, aorta, and the uterine artery. And there was a reliable significant difference in the value of the systolic-diastolic ratio and the blood flow velocity curve of the uterine artery in the studied groups. And the greatest change observed in the GTM combined with anemia when the blood flow in umbilical arteries of the fetus significantly reduced, which indicates disturbance in the mother placenta fetus system. Fetal-placental blood flow disorders of varying severity was noted in the group of GTM in combination with anemia, which accounted for 28.9% of cases. Taking into account the high rates of pregnancy complications as well as the combination of the GTM pathology with anemia, labor ended at home time in 86.8%, which marks a lower result compared to other examined groups. A significantly high frequency of premature births and cesarean section was noted in the group with combined somatic pathology. And the study of the results of anthropometric data of newborns showed that in the general, the average weight of newborns was around 3,300 grams, average height 51 centimeter. And in comparison groups, 18.9% of newborns were born with a body weight below 3,000 grams. Then the group of GTM in combination with anemia it's around 26.3%. And comparative analysis showed that the general in groups with extragenital pathology, there was a high frequency of births of children with perinatal pathology. Every 10th newborn, despite the full-term pregnancy, was born with signs of intrauterine retardation. In a comparative analysis between the groups, it was found that every fourth newborn from the GTM group in combination with anemia was born with asphyxia, central nervous system disorders. And reliable difference were found when we measure glucose levels at 30 minutes after birth in newborns of the study groups. In the GTM group combined with anemia, hypoglycemia was diagnosed in 26.3% of cases. And our results confirm that the combination of GTM and anemia in women has a negative cumulative effect on the fetal development. And the morphological examination of placenta showed that there was an involutional dystrophic change, trophoblast syncytial dystrophy, and stromal edema, which mostly observed in the group of the GTM comparison with anemia, and almost in 77% of cases in a group of GTM combination of anemia, the patient has a stromal sclerosis and the syncytial dystrophy and the involutional dystrophic change in trophoblast. Other frequent and most profound morphological sign of involutional dystrophic process and chronic in the chorionic villi were atrophy of the syncytium, fibrosis of the villi, and the presence of calcification in the intervillar space. And there was also shown that inflammatory changes were found in the villus chorion of all the studied groups. However, there were most often noted that GTM group in combination with anemia, almost 54%, possibly due to the presence of combination of two pathologies, which served as the basis for the formation of lympholymphocyte infiltrates in the placenta subunits. And along the circulatory and involutional dystrophic and inflammatory disorders in the placentas of the study groups, compensatory adaptive reactions take place. Thus, placentas with GTM combined with anemia were distinguished by a high frequency of detection of terminal villi and specialized villi, which form the syncytial capillary membranes to provide the increased volume of blood flow in the intervillar space, while providing an intensive increase in fetal weight with a slight increase in placental weight. A large number of villi with the pronounced angiomatous phenomena in 100% of observations were reliably more often noted in the GTM combined with anemia group than in other groups. And based on the results, all of the Doppler data on placental morphology, it was found that in placentas of human labor with a GTM combined with anemia, in whom blood flow disorders in the mother placenta fetus system were determined in the third trimester of pregnancy, the frequency of morphological signs of damage significantly exceeds all morphological signs in the group of women in labor with their GTM combined with anemia, but with the absence of blood flow disorders in the mother placenta fetus system. Comparison of perinatal outcomes in the study group showed that the newborns with impaired blood flow had lower weight indicators, upper scores in the first and fifth minutes, and were also more likely to be born with asphyxia and intrauterine growth retardation compared to the group without blood flow disorders. And here, the main conclusion points were from this research that based on the results of prospective study of pathomorphological features of placenta, as well the literature review data, we have developed a set of measures for the management of pregnant women. The algorithm for identifying, managing, and treating patients with anemia in the public, including in our study, was carried out according to national standards of antenatal care for pregnant women. And for the first time, we defined the frequency of gestational diabetes in combination with anemia in the country, and also learned the cumulative effect of GTM in combination with anemia on the course of the pregnancy, childbirth, fetal condition, and perinatal outcomes. And moreover, the relationship between the histological features of the placenta and change in Doppler parameters was studied and algorithm for diagnosing and management.
Can I present you my talk about diabetic macular edema, and
You can do full screen mode from
okay.
the
Yeah.
icon.
Yeah. Okay. And
It's given in, yes, it's fully on full screen mode. You can start.
And diabetic mellitus is a systemic disorder whose usually include increase in blood sugar level, and diabetic retinopathy was in 10 years 20%, and in the 20 years in the 6%, and 30 years in 19%. Diabetic retinopathy is one of the microcircular relations of the general diabetic disease and derives from three main factors: lesions of vessel walls, change in blood flow, and change in platelets. And you see normal capillary, and when we see hyperglycemia, vessels and capillaries walls damage, and the vessels walls damage, and after its microaneurysm formation occurred in ischemia formation due to function, thrombocyte damage, and alteration disorders with vascular occlusion. Ischemia forces to increase the level of VEGF factor. And we see retinal hemorrhage, pre-retinal hemorrhage, surface-like flames, deep round dish, and can cause irreversible change the retinal cells. And we see white yellow exodus focus in deep parts of the narrow epithelium. And we see cottonwood exodus, venous alternation, and we see a number of pathological processes contribute to the progressive increase of ischemia in diabetic retinopathy. Pathological process taking place in vessels due to increased glucose level and decreased production of VEGF factor lead to the formation of acellular capillary growth vessels that cannot keep the level of metabolism in retina and sample in which oxygen. Diabetic retinopathy is caused by chronic hyperglycemia, which lead to the damaged retinal capillaries, and you can see this picture in the retina. And diabetic macular edema can develop in any stage of diabetic retinopathy and can cause focal diabetic macular edema, diffuse diabetic macular edema, focal cystoid diabetic maculopathy or diabetic macular edema, and neurosensoric detachment associated diabetic maculopathy or diabetic macular edema. VEGF factor most important role of neovascularization and start endothelial cell proliferation, require cell migration, and prevent APOP. The chronic hyperglycemia, the next step, retinal ischemia, hypoxia, inflammation, and decrease VEGF and PGF factor and inflammation factor. Then we see macular edema and loss vision. In 1948, Michelin's supposed that X factor regulates of growth of vessel both of the normal retina and abnormal neovascularization. In 1989, Ferrara et al. Open VEGF molecule. And I can say to you about the first anti-VEGF drug was a drug to cancer. And next step, ELO and all established correlation between VEGF increase and active retinopathy in diabetic macular edema and vein occlusion macular edema patient. And then in 21-4, approved bevacizumab for colorectal cancer treatment. And next step, bevacizumab was first used for ophthalmic use. And now we have 3 drugs to treatment macular edema, aflibercept, bevacizumab, ranibizumab, and another drug, what I say about this part. VEGF and PGF level are increased in patients with diabetic retinopathy. In PGF factor, significant increase in intraocular PGF in patients with diabetic retinopathy, and the level intraocular PGF significantly correlation with VEGF concentration. And now two factors, VEGF and PGF, significantly increase in patients with diabetic retinopathy. VEGF factor plays a key role in the development of neovascularization, triggers proliferation on the cellular cells, regular migration, and prevents apoptosis. PGF factor also trigger migration of inflammation cells leading of the release of the VEGF and another inflammation mediators, and this internalises in pathological cycle of angiogenesis and inflammation. Hypoxia potential VEGF and PGF factor. And PGF directly binds to VEGF receptor 1, simulating surveyed migration of endothelium. PGF linking with VEGF receptor 1 mediator more effective in contralateral VEGF are linking and VEGF receptor 2, a crosstalk between tyrosine receptor resulting VEGF reception 2 identification. And what we can see, the first PGF diameter link with VEGF receptor 1. The next VEGF receptor 1 signal was activation. The next activation of monocyte and microglia. The next step, secret of pro-inflammatory cytokines. And the next pro-inflammatory cytokines cause future vascular growth factor and then angiogenesis. And I would like to say about clinical study, retinal vascular mobility and the presence to leukostasis, again, the breakdown and increased VEGF production after association in the central grown and selective experimental mouse, and the increased VEGF production in the retina of the mice. This induced by doxycycline to drinking water. And the big picture on the left side, again, the breakdown of the chronic elevation of VEGF production of mice, exhibition increase leukostasis, and the two green images on the left, you can see dilatation of the light vessels coming from the optic disc area between the dilated vessels, the pattern by blood due to separate through the vascular wall. And the next slide, you can see aflibercept contributed to vascular reperfusion result from the chronic increase of VEGF production. And mice with chronic during 7 months elevation and was fluorescein angiography before and after treatment of anti-VEGF drug. And if you see figure 1, I and C, the dark zone without fluorescein, the evidence retinal non-perfusion on this area, and after anti-VEGF administration in some of the zone fluorescein could be observed. And what about patient? The slide demonstrates images obtained with wide field areas of retinal ischemia and circle with a red line. Retinal ischemia, according to fluorescent angiography, is characterized by pronounced hypofluorescein or areas with rupture of vessels associated with microvascular pathology. The image makes it impossible to compare with the visual of area of ischemic retina is characterized by normal capillary architecture. And the clinical case contributes the process of retinal reperfusion, which was observed in the pre-clinical study in mice against the breakdown of the regular anti-VEGF therapy. It is the regularity in the vitreal injection of drug from the group of the contribution to the positive dynamic in the status of retinal perfusion. And regular administration of anti-VEGF drug from regress of the neovascularization and vascular reperfusion. And now we use Lucentis and Elia, two drugs that we used in our clinic and we used in our clinical cases. And if you this article was written about the basic on two rendable healths in the Italy. 12 experts, particular of this 10 leading ophthalmic specialists in retinal disease, and described this position about aflibercept in the treatment of diabetic macular edema. And if you want, you can show and you can read in this article. And I would like show you one clinical cases with diabetic retinopathy and macular edema. This macular edema on right or left eyes, and you can see intravitreal anti-VEGF injection. And the first step we do paracentesis and evacuation for intraocular fluid, and the intraocular pressure was low, and 40 millimeter from limbus in ciliary body. We take needle 27 treated gauge and inject intravitreal injection, Elia or maybe Lucentis, 0.05 milliliter, and you see eyes after injection. And after treatment, you can see macular edema decrease. The first injection, the second injection, and now it's a good result, and the resorption of macular edema. And left eye, after anti-VEGF injection, you can see good result, and now it's visual acuity is better. And in other cases, this cases after intravitreal injection, the first step was vitreoretinal surgery, and then injection to treatment macular edema. The next clinical case you see retina. Then we used vitreoretinal surgery, and then one injection Elia or Lucentis, and we see good result. In conclusion, I would say about VEGF and PGF are main stimulation factor of retinal neovascularization, and drugs can break, and the anti-VEGF drugs can break the pathological cycle and prevent the progression of macular edema and another complication of diabetic retinopathy. Thank you for your attention.
So, hello everyone. I'm Dr. Rambik Ahmed Houais, Assistant Professor in Medical Biochemistry and have diploma in Medical or Therapeutic Nutrition. I'm a head of Nutrition and Dietetics Department at Howler Medical University, Kurdistan, Iraq. So I'm happy to be with you here to share my research topic under the title, The Role of RAC1 in Platelet Chemokine Activation in Diabetes Mellitus. So as previously, my colleagues or participants in the conference have talked too much about the complications of diabetes mellitus, which is a metabolic disorder, which is a chronic disease and affecting millions of people worldwide. So with some acute and chronic complications. So I'm focusing here about zoom in particular aspect of the diabetes that relate to the complications, which is a platelet chemokine activations, and how does this the secretion of this chemokine from the platelet contribute to the challenges faced by the individual with the diabetes. And also I'm going to talk about the role of small GTPases, RAC1. So diabetes mellitus, as I mentioned, it's a chronic metabolic disorder which with elevated blood glucose level, which affect millions of people worldwide, which can lead, and also the complication which associated with the diabetes mellitus can damage the other organs like the heart, blood vessels, eyes, kidneys, and also nerves. So the key process which is involved is in the inflammation, which is a hallmark for the diabetes, and the key process contributing to the cardiovascular disease, it could be platelet activation, also the secretion of the chemokines. So I'm here to explore the role of the RAC1, which is a small GTPase, and platelet chemokine secretion, activation, platelet activation and chemokine secretion in the diabetes, which is associated with the complication, diabetes complications. So RAC1 is a small GTPase, play a vital role in intracellular signaling pathway, and I mean in the physiological condition it has a role, and also which is related to the some cell signaling in the inside our body or inside the animal bodies, which has a role in the inflammation as well, and already has been detected in many other inflammatory diseases, has a role in inflammation under activation. So the hypothesis being explored whether RAC1 induced platelet release of CXCL4 and CCL5 in diabetes mellitus. CCL5, a platelet has many chemokine and cytokines released once it's activated, but I'm focused on the exploring the role of the RAC1 in activation of the platelet and secretion of the CCL5 and CXCL4, and specifically in the diabetes mellitus. Role of RAC1 in diabetes mellitus. What's the role of RAC1 in diabetes mellitus, and what is known before? We know that the RAC1 is small GTPases which exist in the inactive form and then under physiological condition, which exist in the GDP bound inactive form in the cytosol. Once it activated, and the activation it could be done by the guanine nucleotide exchange factor (GEF), which facilitate the exchange of GDP to GTP. Activating RAC1, so the GTP bound RAC1 translocate into the plasma membrane to have a role in the function, cellular function. So activated RAC1 interact with the effector proteins which initiating the downstream signaling pathway underneath. So, and then it can be deactivated. So GTP activating protein gap, which hydrolyze the GTP back into the GTP. So it's turned back into the inactive phase or form by the action of the gaps. Once the RAC1 activated, what happened to the RAC1? What happened to the cells, or what could be happen? So RAC1, as I mentioned, it plays a critical role in intracellular signaling pathway, which is associated with the diabetes mellitus. So it is dysregulation could act as the initiation of the oxidative stress and ROS production, which is so RAC1 regulate NADPH oxidase, an enzyme which is later generating reactive oxygen species, which so that's could be also the ROS production could be as a consequence of the hyperglycemia. So high level of the blood glucose induce RAC1 activation, which enhance ROS production, causing oxidative stress and endothelial dysfunction and damage to the cell or vascular endothelium, which contributing to the micro and macro vascular complications. Beside that, we have also had NOx enzyme, which is leading to the excessive production of the ROS and damage to the endothelial cell, or leading to the cellular damage, which lead to the complications of the diabetes, including macrovascular complication and microvascular complications. So what about the platelet activations? So my study focused, or the aim of my study focused on identify the role of the RAC1 in controlling platelet chemokine secretions during diabetes mellitus. So we have already evaluated the platelet chemokine in the diabetic patient, whether these chemokines can be found in the serum of the diabetic patient. Also, to determine the role of the RAC1, when I say chemokines, I'm focused on the CCL5 and CXCL4. Also, to determine the role of the RAC1 in the diabetes mellitus in activation of the chemokines, platelet activation and chemokine secretion. And also to reveal the mechanism behind diabetes mellitus and its associated complications. So for this aim, and objective, we have used these materials, like we have induced diabetes mellitus in the mice with the streptozocin, a chemical, 45 milligram per kg of the murine or mice, injected intraperitoneally into the experimental mice to produce or to induce the diabetes mellitus, which is a gold standard method to induce diabetes mellitus. Streptozotocin is a chemical compound that targets beta cell, pancreatic beta cell, to induce experimental diabetes in animal model, which mimic diabetes in the human. So the mechanism involved the DNA alkylation and generation of the ROS production and leading to the cell death, which mimic the type 1 or type 2 diabetes. It depends on the dose. Okay. And also we have used the RAC1 inhibitor. In order to find the role of the RAC1, we have used the RAC1 inhibitor, NSC 23766. This is a RAC1 inhibitor, selective RAC1 inhibitor, which is administered intraperitoneally to the animal, 5 milligram per kg. 30 minutes after induction, 30 minutes before induction of the streptozotocin. So the animal were treated using, so the animal pre-treated, treated with the, or induced diabetes mellitus with the streptozotocin and pre-treated with the RAC1 inhibitor in order to know the mechanism behind the role of the RAC1 in regulation and secretion of the chemokines, platelet chemokines. We also, in order to know whether these chemokines are role of the platelet and whether the platelet has already been activated and secrete the chemokines in the diabetic patient. So 150 sample were included in this study from Diabetic Center in Erbil, Kurdistan. Iraq. So human serum also serum collected for the detection of the biochemical test like HbA1c and lipid profile and the liver function test, which is measured by the Cobas Integra. And serum human, beside, in addition to the biochemical test that usually we do for the diabetic patient, we also detected, determined or measured CCL5 and CXCL4 as another new parameter, whether they have high level of these chemokines in the diabetic patient. For the animal, we have used Swiss albino male mice. This is for experiment injected with streptozotocin for induction of the diabetes mellitus. Also daily, because it was like 5-day induction of the streptozotocin in raw, so every day we check the fasting blood sugar for the mice from the tail. Also, beside that, we measured the serum animal CCL5 and CXCL4. Also, histology of animal organs done for the lung, liver, kidney, and pancreas. RAC1 activity assessed by the pull-down assay, purification of the RAC1 protein, and doing the Western blotting for the sample, platelet sample, which is extracted from the blood of the mice. So as shown in this table, demographic and clinical characteristic of the diabetic patient. The study, as I mentioned, includes 150 diabetic patients, including male and female. The age ranged between 8 to above 70 years, with the mean age of 52 years. So blood glucose and HbA1c, fasting blood sugar and HbA1c level detected or measured in the diabetic patient, which were higher in compared to the control group. So they are indicating they are hyperglycemic, confirming poorly regulated glucose level. Also elevated HbA1c, which is it means the chronic hyperglycemia, which is a hallmark for the diabetes mellitus. Also, lipid profile, we have already measured lipid profile, including total cholesterol, triglyceride, LDL cholesterol, and HDL. So lipid profile abnormalities, there's abnormalities in the diabetic patient. So the significantly higher level of the total cholesterol, triglyceride, and low density lipoprotein in the diabetic patient, indicating dyslipidemia, which is a comorbidity associated, a common comorbidity with the of the diabetes, contributing to increased risk of the atherosclerosis or cardiovascular diseases. Beside high density lipoprotein, which is there's a significant reduction in the diabetic patient, which is compromised lipid transport system, further exacerbating the cardiovascular risk. So there's also we also what measured also is the liver function test, including AST, ALP, ALT. So there's a significant increase AST in the diabetic patient compared to the control group, same ALP, and higher ALT in the diabetic patient compared to the control group, but it is not significantly increased. It's only 1.2-fold increase in the diabetic patient without significance. Streptozocin-induced diabetes mellitus in the mice. In order to confirm that the streptozocin, a chemical that induced diabetes mellitus, to confirm that, we already injected mice with the streptozocin and pre-treated with the RAC1 inhibitor to know the role of the RAC1. So injection of the 45 milligram per kg body weight of the mice of streptozocin into the mice significantly increased the fasting blood sugar of the mice compared to the sham group, as you see in this figure. So with a p-value of less than 0.05. However, the group which is pre-treated with the RAC1 inhibitor markedly reduced the high blood sugar induced by streptozocin. So pre-treated mice with the RAC1 inhibitor reduced fasting blood glucose and also attenuating RAC1 activation by the, as you see in the this picture, the bar that you see here, also the lane of the Western blot of that blot, Western blotting. So activation of the RAC1, it increased the activation in the vehicle, which is induced or treated with the streptozocin, and also the lane beside, which is pre-treated with the RAC1 inhibitor. There's a reduction, a significant reduction, as you see in the figure beside. Normalization. It indicates the reduction of the RAC1 activation in the diabetic mice. Diabetes mellitus also increased the plasma level of the CCL5 and CXCL4 in the patient, in the diabetic in the patient with the diabetes. There's increase in the CCL5 and CXCL4, which they are platelet chemokines. So in the patient, in order to know or to confirm there's increase of these chemokines in the patient or in the diabetic patient, we have used or determined the human CCL5 and CXCL4 in the serum of the diabetic patient, and there's more than twofold of CXCL4 and threefold of the CCL5 increase in the diabetic patient. Beside that, we found induction of the diabetes mellitus by injecting streptozocin in the below figures. In the mice, we measure CCL5 and CXCL4 by ELISA. So induction of the diabetes mellitus by streptozocin significantly increased the CCL5 and CXCL4 in the mice. However, pre-treatment with the RAC1 inhibitor significantly reduced CCL5 and CXCL4, indicating the role of the RAC1 in the controlling the secretion of the platelet chemokine secretion. So histological alteration of the kidney and pancreas in the diabetic mice. In order to know if there's any morphological changes in the organ of the induced mice with the diabetes mellitus, so histological analysis revealed that streptozotocin induced pathological changes, including inflammation, necrosis, fibrosis, degeneration, also vascular congestion and edema also in the kidney and pancreas and other organs. So streptozotocin exposure caused significant kidney and pancreas damage or injury with the marked degeneration as it's shown with the row, and inflammatory cell infiltration of the inflammatory cells into these organs in the pancreas and kidneys. So, which score in the diabetic mice and showing the significant increase of the inflammation and degeneration in these organs. While administration of the RAC1 inhibitor or pre-treatment with the RAC1 inhibitor markedly reduced these scores. Same for the other organ in the histopathology of the liver and lung in the diabetic mice. So histopathology showed normal rival architecture in the normal, while streptozotocin induced diabetes mellitus, diabetes caused vascular congestion, hepatocyte degeneration, and lymphocyte infiltration or immune cell infiltration. However, pre-treatment with the RAC1 inhibitor or which induce streptozotocin-induced liver damage with the pre-treatment with the RAC1 inhibitor can attenuate this damage. So liver injury score were significantly higher in the diabetic mice in compared to the sham, and improved this damage with the pre-treatment with the RAC1 inhibitor. In conclusion, inflammation is considered as a hallmark for the diabetes mellitus, and under inflammation, platelet will be activated. And activation of platelet, it means a secretion of the chemokines, particularly in the development of the and progression of the chronic low-grade inflammation, like both type 1 and type 2 diabetes involve or can induce low-grade inflammation or inflammatory responses. And pro-inflammatory cytokines can be secreted in immune cells beside the platelet that I have investigated. So it can induce the oxidative stress, which is leading to the oxidative stress, leading to the damage of the pancreatic cells, specifically pancreatic beta cells, which is one causes of this stress. It is a hyperglycemia, which leading to the destruction of the pancreatic beta cells and leading to the RAC1 activation. So ROS production because of the hyperglycemia leading to the RAC1 activation, and RAC1 activation, blocking of the RAC1 activation, leading to the less complications like macrovascular and macrovascular complications. Why? Because platelet is involved in the thrombus formation, and the platelet chemokines CCL5 and CXCL4, once it's activated, these chemokines is secreted and leading to the thrombus formation. And thrombus formation, which lead to the diabetes mellitus complication, which is we have both macrovascular and microvascular complications. So by demonstrating the role of the RAC1 in different mechanism of inflammation and find out its potential pharmacological benefit in treatment because of the RAC1 function, which might provide important therapeutic avenue. So we explore the benefits and potential drawback of the targeting RAC1 in if we explore it in the clinical setting. So it could be it could provide an overview of available compound that target RAC1 activity mechanism, which is leading to the, it can lead to the.
Thank you, Doctor. Actually, we are already ahead of time. Can you please conclude?
Yeah, this is the last slide. So it could be a new drug discovery for complication which is related to the diabetes mellitus. Thank you.
My topic today is about utilization practice of herbal medicine in patients with type 2 diabetes in Kuwait and their perceptions about this use. I am a professor of public health and preventive medicine, Tantak Faculty of Medicine, Egypt. Also, I am lecturer and tutor for public health graduate studies in the University of South Wales, UK, and lecturer and tutor of Master of Clinical Research in Warwick University, UK. We will begin by the introduction, and the use of herbal medicine or alternative medicine is widespread worldwide, especially among patients suffering from chronic diseases as diabetes mellitus, cancer, rheumatoid, and these are chronic diseases. So the WHO, the World Health Organization, defined complementary medicine as a diverse health practice, including the use of herbal medicines, mineral-based medicines, and animal parts, which are used as a single material or in combination to treat, diagnose, or prevent illness and maintain the well-being of the individuals. Type 2 diabetes is highly prevalent among the Gulf countries, where the prevalence, for example, in Kuwait, it is 1.1%, 20 patients for every 100 patient for 100 person in Kuwait. Also in Saudi Arabia, I think the prevalence is very high, is about 30%, and 1 person from 3 persons in Saudi Arabia are diabetic. We are afraid from diabetes due to it implies significant morbidity and mortality from various microvascular complications like retinopathy, nephropathy. Nephropathy ends usually with chronic renal failure, and neuropathy and macrovascular complications like ischemic heart disease, hypertension, stroke, and peripheral vascular disease. Complementary medicine and alternative medicine is usually used worldwide. For example, in the United States, reports of Center of Disease Control and Prevention show that 40% of adults and 10% of children have used complementary medicine in their treatment. Australian data also shows that 64% of people has used one or more methods and modes of complementary medicine in the previous 12 months, and the proportion of patients using complementary medicine over 1 year was 23% in Denmark and about 50% in France. In Gulf countries like Saudi Arabia, about 30% of patients with diabetes were using herbal medicine to treat their metabolic status. As it is well known that some herbal remedies are proven to provide symptomatic relief of the symptoms and helps in prevention of complication of diabetes mellitus, and some are proven to help in regeneration of beta cells of pancreas and in overcoming the insulin resistance and improving the insulin sensitivity, and also improving the glycemic control in diabetic patients. This is only one of the plants used in treatment of diabetes in most Arabic countries. The chronic course of diabetes mellitus and its composition pushes the patient to use alternative medicine. Sometimes the patient becomes anger, and I think the treatment for diabetes is boring, so they change their modality of treatment. Alternative therapies are gaining public acceptance and widely used in the globe, especially in patients with chronic diseases like type 2 diabetes mellitus. As we said before, the patient may be dissatisfied by the ordinary and conditional treatment. Most of the drugs have side effects, maybe diarrhea, maybe constipation, proceed to hypoglycemia, and the traditional methods may coincide with the patient's values, spiritual and religious, and beliefs regarding the nature and the meaning of death and illness. The aim of the study or objective of this work to investigate the prevalence of type 2 diabetes mellitus patients using herbal or alternative medicine in treatment of glycemic state in the state of Kuwait. Such investigations aim to provide essential evidence for guidance decision makers and individual levels. The patients and methods, this is cross-sectional study, quantitative type, showing the prevalence of studying with the prevalence of herbal medicine, use of herbal medicine to treat diabetes. It took about from January 2019 to June 2019, about 6 months in the diabetes clinic in Farmania Hospital in Kuwait. The study population, the sample size. This sample size, I don't go in details. This is the equation for estimation of the sample size. And these are the abbreviation where the total size of population selected for this study is 350 patients with type 2 diabetes mellitus. We have chosen the patients more than 18 years of both genders, males and females, and have been diagnosed with type 2 diabetes at least for 1 year prior to that to be included in the study. So the sampling technique was the systematic random sampling. Every 4 patients attending to the clinic is selected for the study, and the data were collected by diabetes physician or nurse through face-to-face using questionnaire sheet adopted and modified from previously developed and validated studies on herbal medicine use. The structured questionnaire sheet consisted of 24 items, and the ethical approval is obtained from ethical committee from the Ministry of Health in Kuwait. The statistical analysis, we used the SPSS statistical program for software version 23. We used the chi-square test as the test of significance for categorical data, and we considered significant level when the p-value is equals or less than 0.05 was considered significant. These are the medicinal plants and herbs used in management of diabetes. These are the beans. These are the aloe vera, phytermelone, fenugreek. This is fenugreek. This is Ficus garcia and ginger. The results of this study, we showed that about 30% of the total total diabetic patient were using herbal medicine in their treatment of diabetes. This is table number 1 shows that the socio-demographic characteristics of herbal and non-herbal user in the study. Most of patients were about 40 to 60 years in age. In 50% of the herbal user and 39% in non-herbal users. Females were more using herbal medicine than males in the herbal users. The educational level, most of the patients have more than 12 years of education, about 50% of both herbal and non-herbal user. The nationality, most of the study sample was Kuwaiti, about 74.8% compared to 82.7% in non-herbal user. The monthly income, most of herbal users have a middle monthly income that lies between 500 to 1,000 Kuwaiti dinar, and most of the non-herbal users were high monthly income, more than 1,000 Kuwaiti dinar. It consists of 41.6% of the non-herbal user. This table shows the varieties of plants and herbal medicine used in treatment of diabetes, and the total number of 107 patients. The fenugreek, or in Arabic, helba, was used in 10 patients. Black cumin, or in Arabic, habba soda, it is in 15 patients, about 14%. The cinnamon, this is the picture of cinnamon. It is called in Arabic darasen. It is in Latin name cinnamomum, xylenicamblone in 12 patients, the bitter apple or hand thal in 10 patients of herbal users. Most of the patient was using herbal mix done by the herbalist. About 17 patients, consisting about 16% of the patients. Also white lupin in Arabic terms or Lupinus albus in 6 patients. The garlic was used in treatment of diabetes. It is in Arabic tome. It is Allium sativone in 11 patients. The onion, as sure as I demonstrated before, used in 7 patients. The aloe vera or sabr aloe vera, 5 patients, and the wormwood is used in 5 patients. More than one type of the herbal medicine was used in 9 patients with diabetes mellitus. This table number 3 shows the family history of diabetes mellitus. Was present in 58% in the patients using herbal medicine and 53% in non-using, with non-significant statistical difference between the two groups. The duration of diabetes, most of the patients has more than 5 years of disease, 60% in herbal user and 58.4% in non-herbal user, and there is no significant statistical difference between the two groups. We come to an important point, which is the continuity of care. The patients goes to the diabetes clinic or primary health care center where there is a diabetic clinic. The follow-up is present in 40 patients, 37.4% compared to 40% in the non-herbal user. The follow-up in different centers was 62.6% compared to 60% in non-herbal user. But the majority of the herbal users were not on regular basis visiting the healthcare center or diabetes clinic. Only 30% compared with non-herbal user 65.8%. Also, the number of annual visits was very low in patients of herbal users, depending on the fact that they get medicine, herbal medicine that will help in management of glycemic status of diabetes. This is the diabetes control table showing the glycemic control, where we consider the uncontrolled diabetes is less than or 7%, and this was present in herbal user, 31 patient, about 30%. In contrast to the non-herbal user, 60%, with no significant statistical difference between both groups. The type of treatment, most of patients were using the oral tablets in their treatment of diabetes. The regimen of treatment most of the herbal user was regular using medical treatment. About 87.9%, and the complications was present in 71% of the herbal user compared to 16 or 17% in non-herbal user, but still there is no significant statistical difference. I think the statistical difference was between the diet and regular and irregular medical treatment, as the p-value is 0.302. We come to an important table which the perceptions of patients about their herbal user. Who described these herbal plants for you? Self-option in 5 patients. Friends described these plants for us in 74 patients. Family said that it is beneficial in treatment of diabetes in 15 patients. Through the media and social media, internet, WhatsApp, Instagram, and so on, in 13 patients. What are the indications for use of these plants? Some patients said that they are supportive to our medical treatment in 15 patients. Loss of confidence with the drugs, 31 patients, about 30%, they are not confident that the anti-diabetic drugs are more potent and potential to control their glycemic status. To avoid the complications of the side effects of the drugs in 10 patients and more than one cause in 16 patients, about 15%. We asked the patient, do you experience side effects while using these plants? They 30% said yes, and 70% said, 70 patients said no, not sure in 7 patients. The problem in using the herbal medicine by the diabetic patients is that it is a secret, and they are not telling their doctors about using herbal medicine beside the ordinary diabetic treatment. And this was present in about 60% of patients, and use of conventional treatment, the diabetes, when using the herbal medicine with conventional treatment, it is 60%, and not using with conventional treatment in 35%, and sometimes in age patients. The frequency of intake, daily in 42 patients, weekly in 50 patients, other 15. Satisfaction, most of patients were satisfied by their plants. 18 patients, about 75%. Some are not satisfied, 20 patients, about 19%. Informing the treatment doctor, as I said before, most of the patients did not tell the treating doctor, as they are using herbal medicine beside the conventional treatment. So we can conclude from this study that 30% of the sample were using herbal medicine for management of diabetic state. So it is a great need to raise the awareness of diabetic patient about the side effects of herbs. So in this situation, I invite the pharmaceutical industries in order to take these plants and see what is the active principle in these plants that lowers the blood glucose level and can make herbal drugs that can help the patients. But I think this is will not come in true because, as we know, the industrial system is concerned with making money, not only for the sake of the patients. So we must pay attention dedicated to educating the patient with type 2 diabetes mellitus, especially those with family history of diabetes and those who had disease for a long time. We make patient education for every diabetic patient about how to use the drugs, how to even use the herbal medicine, but beside the conventional treatment. Not only I saw many patients with very high blood sugar level with using only the herbal medicine or plants. So we have a concerted effort by the government and orders the medical school to enhance the use of complementary therapies that are proved to be safe. We are aiming to know if these plants are safe for the patient, no severe side effects, not affecting any organ like cinnamon may affect the liver, may affect the kidney. Some are, we don't know the side effects of this herbal medicine. So at the last point, I thank you for your attention and listening, and thank you for organizing committee for inviting me to this nice meeting and nice conference. Thank
the guest of Message Across. Thank you for your invitation. I will speak about hyperglycemia, impact of initial hyperglycemia on mortality in reanimation. I'm an anesthesiologist. I'm from DRC. It's a study we do at University of Kinshasa in DRC. Hyperglycemia is defined as a cross in blood sugar beyond 6.1 millimole by liter on an empty stomach. Carbonate intolerance when blood sugar is between 7.8 and 11.1 millimole by liter on an empty stomach at 120 minutes of a hyperglycemia test. Hyperglycemia is considered as one of the determining factors of morbidity and mortality in intensive care. Our subject is to assess the impact of initial hyperglycemia on the mortality of intensive care patients. About methods, The study is a cross-sectional study involving 217 patients from number 1 to 2012 to July 31, 2030 on the patients admitted in the intensive care unit of University of Kinshasa Hospital and the Ngaliema Clinic in DR Congo. All patients admitted in intensive care unit during the study period and in whom blood glucose was measured during the first 24 hours. After selection, the sample made up of 217 patients, including 108 cases of hyperglycemia and 109 cases of normoglycemia. Patients were divided into two groups, a group of hyperglycemic patients and a group of normoglycemic patients. From the hyperglycemic group, the patients were divided according to whether they were known as diabetic beforehand or not. Patients were registered in order of arrival in the intensive care unit. Blood glucose level were measured on two samples taken 8 hours apart to exclude the possibility of postprandial hyperglycemia. Patients were managed according to the institution's usual therapeutic standards, as were comorbidities and other associated conditions. From patient file, data were collected and stored into the computer using a PM4 software and analyzed using the SPSS version 21.0. The Q-square test feature exact associated with the risk calculation allowed to compare the hyperglycemic group and the normoglycemic patient, and also the previously non-diabetic hyperglycemic and the non-diabetics. The p-value lower 0.05 was the first and of statistical significance. About the result, please. Please. My computer, do something. Please. Okay. First table is for representation of patient hyperglycemic profile of patient according to age and gender. That's the patient aged over 45 years had more hyperglycemia with significant difference. First figure is represented the patient by origin. The vast majority of patients came from emergency room. The first figure that represented the patient according the region of admission, polytrauma, digestive surgery, and sepsis, was where the region major for admission. Second table represented patient according to blood glucose and outcome. A group of hyperglycemic aids, the hyperglycemic head presented more ditch than the normoglycemic with a significant difference. Third table represented patients stay according to glycemia. That the long stay was observed more in normoglycemic than in the hyperglycemic with a significant difference. Here I can do some, I will say that because more of patients hyperglycemic were died. And the hyperglycemic, the normoglycemic stay au-delà de 5 jours, j'ai oublié. Four table represented patient outcome according to their story. Here, we had more deaths in the stay. They were more deaths in the stay of less than 5 days with a significant difference. A 5 table represented of a patient to the outcome of hyperglycemia patient according their story. A group of non-diabetic hyperglycemic patients had more ditch. About discussion, hyperglycemia is frequent in intensive care, whether the patients are diabetic or not. Even a modest degree of hyperglycemia, please, my computer has a problem. Please. Even a modest degree of hyperglycemia on admission to intensive care was significant to significantly increased the risk of death during hospitalization. Limitations, yet ideally, this study would have been based on previous data that was not done, especially in collecting the necessary information. Finally, patients of different age and sex were included in the present study. Conclusion, mortality was high in the group of no diabetic hyperglycemic patients, 88.9% versus 11.1% of hyperglycemic diabetic patients. Thank you.
Okay, so I was saying that diabetes is characterized by blood sugar by a blood sugar level higher than 1.26 gram per liter, and we distinguish two main types of diabetes. The type 1 and type 2. Type 2 represents 90%, while type 1 represents 10%. And this diabetes is, the number of people suffering from this disease is increasing all over the world, 51% in the world, while in Africa, we have 143% increase. And this increase in Africa may be due to urbanization and lifestyle. We also have some consequences related to this disease, some complications, I mean, like nephropathy, retinopathy, neuropathy, and coma. So the treatment is available for this disease, and it is based on the lifestyle and dietary measures. It is also based on oral antidiabetics and insulinotherapy. We have some drugs that can also be used, and we also know that these available drugs and even some medicinal plants, not all, can be used to fight against this disease. But the problem is that these available drugs are of high cost. Some of them are toxic and present side effects and undesirable effects. So all these difficulties increase the prevalence of the disease as well as these complications, particularly diabetic nephropathy in Africa in general and in Chad in particular. In 2019, diabetes and kidney disease due to diabetes caused approximately 2 million deaths worldwide. Yet in Chad, little research has been carried out in the field of diabetes, resulting in the lack of data and diabetes management strategies. So it is on the basis of this observation that this study was carried out in order to bring light on the influence of type 1 diabetes on the renal function of children from 1 to 17 years old at the Mother and Child Hospital of N'Djamena, Chad. Concerning the design and study population, we will say that the study was a cross-sectional study conducted at the Mother and Child University Hospital Center of N'Djamena, Chad, from April to June 2023. The National Ethics Committee validated the study protocol for human health in N'Djamena. The participants of the study were all type 1 diabetics, children and adolescents, aged 1 to 17 years, distinction of sex, whose consent and informed consent of the parents were obtained. Concerning the collection of blood samples, a questionnaire sheet was submitted to participants who gave their assent and whose consent was obtained, as well as a blood collection of a volume of 5 milliliter at a bend of the elbow using an alcohol swab and a syringe attached by needle. Also, a collection of urine was made. The blood sample was collected in the lithium heparin tube and then centrifuged at 3,000 rounds per minute for 5 minutes to obtain the serum. The latter was therefore separated from the plasma in microtubes for analysis. Concerning the sample analysis, yes, the biochemical examinations included blood sugar, creatinine, uremia, which were performed using the spectrophotometric methods. We also measure nitremia, chloremia, and serum potassium using the ionic S-free automated ion analyzer. Glucosuria, ketonuria, and proteinuria were also measured by colorimetry using urinary script. And as a result, the study focused on 61 type 1 diabetic patients, and who were followed at the Mother and Child University Hospital Center of Jamina, and those newly received in the laboratory and pediatric 2 of the SET center. Among these patients, 55% were male, while 44.3% were female, and the average age of this study population was 12.85, with a standard deviation of 3.01 year. So this table shows what we've just said. Then the population was divided into 3 groups. The age group from 11 to 17 years was the most represented and constituted 85.2% of the population. The majority of participants had a primary education level and lived mostly in urban areas. And the average fasting blood sugar observed in these patients was 4.54, with 99.99% of participants in a situation of hyperglycemia. Similarly, the average glycated hemoglobin for these patients was 10.71%, with a standard deviation of 2.73%. And the patients were divided into 2 groups according to their glycated hemoglobin level. Those with a level greater than 7%, and who was called poor glycemic control group, represented 86.9% of the population, and those with a rate below 7%, whose glycemic control was well performed, represented 13.1% of the population. Most of the children were of normal weight, and the average body mass index was 17.06. And as far as renal parameters, hypercreatinemia were concerned. They were what I mean, as far as renal parameters were concerned, hypercreatinemia was observed in 45.9% of the study population, with an average of 11.09 milligram per liter. While in most cases, hyperuremia was observed with an average of 0.36 gram per liter. So 63.9% of patients showed hyponatremia with an average of 131.54 millimole per liter, while hypokalemia was observed in 47 of the children, with an average of 3.01 gram per milliliter. per liter. I mean, okay. Now the table 2 below shows or summarizes the effective mean of the parameters, while the average body mass index during this study was 17.065. It appears that 67.2% of the study population had normal weight, 27.9% of slimming patients, while 3.3% were overweight. The analysis of the descriptive statistics through the cross table gives the number of participants by age group for the quantitative parameters studied. For the body mass index, the most represented age group is that of children aged 11 to 17 years. All patients were in the situation of hyperglycemia, and 84.9% had a glycated hemoglobin level greater than 7% in this age group. Hypercreatinemia and hyperuremia in this subpopulation were 82.14% and 92.30% respectively. For iron assays, 84.61% of children were hyponatremic, 82.97% hypokalemia, and 82.92% hyperchloremia. According to age group, there is no significant difference between different biochemical parameters. The high level of ketone bodies in the urine was observed, and it was more frequent in type 1 diabetic children with poor glycemic control compared to those with good glycemic control. It is the same trend with glycosuria, however, with different contributions that can be observed in the table. Hypercreatinemia is higher in the children with poor glycemic control than in those with good control, with percentage of 49.1 versus 25. End stage and early renal failure are 1.9 and 32.2% prevalent in children with poor glycemic control, while lower percentages were observed in those with good control. Hyperuremia also has the same tendencies as hypercreatinemia. As far as ions are concerned, the values are more or less in favor of an increase of chlorine or a decrease of sodium in the blood level. Moreover, no distribution of the variables between the two groups was significant. The mean of ketonuria is 0.4 against 0.4063 against 0.4915 respectively in children with good control and those with poor control. The average glycosuria in children with good control is higher than that of the group with poor control. The same is true for glomerular filtration rates, potassium and sodium. The variation of these averages is opposite for the case of urea and chlorine. The p-values are in no way significant for all the parameters evaluated. And all patients were on treatment, and not only patients treated with insulin were included, but also those taking oral antidiabetics. 93.4% of patients were on insulin, 3.3% were on oral antidiabetics, and 3.3% were taking both insulin and oral antidiabetics. While 93.4% of the study population reported having a a glucometer for self-monitoring of their blood sugar, 6.6% did not. Since puberty is a parameter influencing glycemic control, 42.6% of patients were unaware of their puberty status. 32.8% had normal puberty and 24.6% had delayed puberty. It should be noted that despite all this, 95.1% of children had tachycardia. The survey sheets revealed that only 23% consume cow milk. These results are shown in this table. So from the figure 1 below, we can observe that the distribution of patients according to glycemic control and the duration of diabetes is presented, and the population with a higher poor glycemic control was that of children whose diabetes is inaugural, just discovered. As the duration of discovery of diabetes increases, the poor glycemic control decrease. The chi-square test permitted to distribute the renal biochemical abnormalities according to the duration of diabetes in table 8 below. From this table, it appears that the prevalence of terminal renal failure is 2% in the group of children with inaugural diabetes against 0% in the other groups. The early renal failure is also high in children with inaugural duration of diabetes, with 15% against low numbers and percentages in other groups. The same observations were made for other abnormalities such as hypercreatinemia, hyperuremia, hyperchloremia, hyperglycosuria, and hyperketonuria. Abnormalities such as hyponatremia and hypokalemia were also more prevalent in children with onset diabetes. All these results show that abnormalities in renal biochemical parameters are more frequent in diabetic patients, in diabetic children with inaugural duration than in other diabetic children. And these results are summarized in the on this table. So the average of the renal parameters are also divided according to the duration of the diabetes. And the table 9 shows this. And from this table is the observation shows that parameters like ketone bodies gradually decrease as the diabetes lasts. The children with inaugural duration have an average ketone life. These trends are the same with the glycosuria with respective values of 10.5, 10.41, 6.87, and 2.5, according to the gradual duration of diabetes as shown in the table 9 below. However, the other renal parameters showed no significant differences. The Spearman correlation test carried out shows positive and negative association with significant differences between the parameters, in particular between the level of creatinine and urea, with a p-value of 0.01 and between the glomerular filtration rate and creatinine with a p-value of 0.01, respectively positive and negative. And a negative association between the duration of diabetes and the rate of ketone bodies with P equal to 0.05 between the body mass index and the chloride ion were also observed. These correlations are listed in the table, in this table. And descriptive statistics using the chi-square, they showed the results of a p-value of the parameters as a function of the glomerular filtration rate. From this table, it appears that H, potassium, iron, ketonuria, and cow milk are associated to glomerular filtration rate. And as conclusion to this study, we can say that from this study, it emerges that the alteration of renal function of the study participants through altered renal biochemical parameters is linked to poor glycemic control and the duration of discovery of diabetes. This data could be exploited for healthcare benefits in children with type 1 diabetes. Thank you for your kind attention.
Poster is named Clinical Evaluation of the markers GDF-15 in the early diagnostic of diabetic cardiomyopathy and diabetic nephropathy in patients with type 2 diabetes in a Bulgarian population. The ease of measurement of some biomarkers released early in response to tissue damage makes them invaluable in diagnostic algorithm. One of them, differentiation growth factor 15, is known to be a cytokine of the transforming growth factor beta family and reflects metabolic and cardiovascular disorders. We decide to evaluate the diagnostic weight of GDF-15 in the early stage of diabetic cardiomyopathy and diabetic nephropathy in patients with diabetes 2 mellitus in the Bulgarian population. This is pilot study for our country, comparing it with other popular cardiovascular biomarkers. In study included 34 patients with diabetes 2 with glycated hemoglobin less than 8.5%, BMI less than 35 kilograms per square meter, age less than 75 years, without a history of atherosclerotic vascular, cancer, and other serious disease. Patients were divided into 4 groups. You can see in poster. In addition to history and physical examination, the diastolic function was assessed in each patient with a 2D echocardiographic examination. GDF-15 and terminal pro-brain natriuretic peptides, high sensitivity troponin I, interleukin 6, and 24 hours albuminuria are examined in the laboratory. We find high GDF-15 in conclusion. We find high GDF-15 was found in 75% on the study patient compared to 26% for NT-proBNP, 23% for interleukin 6, and 3% for the troponin I. High GDF-15 levels prevalated up to 15.2% in the groups with diastolic dysfunction and microalbuminuria below 30 milligrams per square 24 hours. Diastolic dysfunction was found in 76% of all patients, 69% of whom had microalbuminuria below 30 milligrams for a day. And in this group, 18% had elevated GDF-15 with concentration very high. On the examined patient, 30% had diabetes nephropathy, where GDF-15 results 4 times higher than the norm was registered, correlated with the high troponin and anti-proBNP. All patients with high interleukin-6 and reduced glomerular filtration had elevated GDF-15, but only 68% of patients with high GDF-15 had elevated interleukin-6. In conclusion, this pilot study confirmed GDF-15 as a useful marker for early and rapid vascular risk stratification in patients with diabetes 2 mellitus. The study is ongoing, and perhaps next year we will be able to present the final results. Thank you for attention.
Good evening. My name is Ariadne Beatriz. I'm very honored to be here. Thank you to the committee for the invitation to present my final paper. That is very important to me. Thank you to the other authors of the article, and thank you to the Universidade do Extremo Sul de Santa Catarina, UNESCO, em Criciúma, Brasil. Diabetes mellitus, DM, is defined Good evening. My name is Ariadne Beatriz. I'm very honored to be here. Diabetes mellitus, DM, is defined as a... Good evening. My name is Ariadne Beatriz. I'm very honored to be here. Thank you to the committee for the invitation to present my final paper. That is very important to me. Thank you to the other authors of the article, and thank you to the Universidade do Extremo Sul de Santa Catarina, UNESCO, em Criciúma, Brazil, that made it possible to carry out this research in the clinic in its dependencies. I'm a doctor. I graduated in 2021 in that university. In UNESCO, there are several areas of activity that aim to interdisciplinary and scientific research. In January of 2023, there were 6,531 consultations in the dependence of these clinics. This article is the result of my final paper in the medical school. I chose this subject because I admire my mentor, Professor Liliane, who is a nurse specialized in diabetes, and because I realized the importance of multidisciplinary work for the best management of these patients. Diabetes mellitus, DM, is defined as a serious chronic disease present when the pancreas does not produce enough insulin or when the body does not correctly use the synthesized insulin, resulting in chronic hyperglycemia. The condition leads to several micro and macrovascular complications affecting the quality of life of individuals, which may lead to a significant reduction of life expectancy. DM is a worldwide problem, with its numbers increasing from 108 million in 1980 to 422 million in 2014. Currently, there are about 425 million people with diabetes in the world, comprising 8.8% of the global population between 20 to 79 years old. Of those, at about 79% live in underdeveloped countries. If this trend continues, it is estimated that by 2045, 6,029 million people will have diabetes. 629 million, sorry. Brazil ranks in fourth in number of diagnoses with 13 million of patients, just behind China, USA, and India. The most common subtype is type 2 diabetes mellitus, DM2, which is 90 to 95% of cases and is generally associated with overweight sedentary lifestyle, smoking, and a positive family history for DM. DM2 affects mainly adults from the age of 50. However, it has been observed an increase in young people, justified by the current lifestyle. The disease styles itself insidious, and the symptoms may take many years to appear, being frequently the diagnosis when complications, acute or chronic, are already present. In order to identify the onset of this complication early, diabetic individuals should be evaluated periodically through clinical and laboratory tests. Chronic complications include retinopathy, nephropathy, heart disease, cerebral vascular disease, neuropathy, and peripheral vascular disease, PVD. The last two added to orthopedics and infection alterations when present in the feet or in the lower limbs of diabetics, individually or in combination, are referred to the diabetic foot, which affects approximately 15% of these individuals. Peripheral neuropathy is the most frequent problem associated with diabetic foot, and it may affect sensory, motor, and autonomic fibers. The impairment of the sensory fiber causes a gradual decrease in protective sensitive and its perception of plantar pressure, temperature, and proprioception of the foot. The damaged autonomic component generates a reduction of foot sweating, leaving them dry and susceptible to the development of injuries. Alteration in the motor part of the nerves lead to atrophy and dorsal muscle generation, osteoarticular deformity, and maladjustment in walking. Diabetes foot complications are a common cause of admission of diabetes to hospital, and they are the main determinant of quality of life for these patients. Ulcers are the most prevalent consequence, with an annual incidence of 2 to 10% in developed countries. The lifetime risk of an individual with DM to develop ulcers exceeds 25%, and they can become serious with gangrene and infection, and due to the underlying disease itself, the healing of these lesions is usually compromised, ultimately requiring local amputation. About 40 to 60% of non-traumatic lower limb amputation are caused by DM, and of these, 85% are preceded by ulcers. The number of amputations in diabetes is 10 to 20 times higher compared to the population without the disease. In terms of mortality, approximately 10% of the patients who amputate the lower limb die in the preoperative period. 30% die in the first year post-amputation, and 50% in third year, and 70% in the fifth year. To determine the prevalence, the object of this work is to determine the prevalence and risk factors associated with amputation to DM, focusing on aspects related to basic care, self-care, and socioeconomic profile. The present study presents a quality and quantitative approach of a cross-section and descriptive nature, seeking to understand the risk factor and the prevalence of mutation in patients with DM. The research took place in an integrative clinic of a university in southern Brazil during the periods from March to August of 2019. The sample was randomly composed of 42 patients with lower limb amputations who were assisted by university clinic, and of these 36 have diabetes mellitus as the cause of amputation, forming the final sample. The remaining 6 patients entered the study by way of prevalence analysis. As exclusion criteria for the sample, patients should be over 18 years old and present some amputation in the lower limbs. The data collected was organized and analyzed by using the IBM statistical package for the social service science version 22.0, was divided in The data collected was organized and analyzed by using the IBM statistical package The importance of identifying risk factor is related to the prevention of both the first amputation and future ones, since 30 to 50% of patients who need an amputation will require additional amputations in 1 to 3 years. The prevalence of amputations due to diabetes mellitus observed in this study was 85.7%, a rate similar to the obtained by Martins of 88.6%. Regarding the age range, the average age found in the survey was 63.17 years old, equivalent to the result of work by Gomez. That average was 60 years old. respectively. Santos et al. Found in their study that 61.2% of the sample were in the 60th decade of life or more. In several studies, age above 60 years old has showed a risk factor linked to the installation of diabetic foods and subsequent amputation. The natural aging process implies a gradual and progressive decrease in the functional capacity that, when associated with other factors such as diabetes itself and lower education, can result in the development of complications, especially due to the difficulty in self-care. In terms of gender, 75% of the sample consisted of males, similar to result found by Alverson. According to a research carried out with the object of investigating the difference in self-care with the fit and in lifestyle between women and men with diabetes, men present worse results, lower frequency of drying between the toes, periodic evaluations of the feet, habit of walking barefoot, unsatisfactory hygiene, and inadequate nail cutting. In addition to higher rate of smoking, alcohol intake above the recommended level, deficit in dietary control, and lower frequency of laboratory tests were the results observed. Low schooling was imperative in this research, with 72.2% of respondents completed only elementary school, a fact consistent with some studies observed. Regarding to diabetic foods, bowel presents the percentage of 72.85% of its participants completed only elementary school. The level of education influences adherence to treatment, enabling better glycemic control and consequently the prevention of complications. Poor schooling makes this teaching and learning process difficult, which is a fundamental step in education diabetics to develop self-care skill with their feet, exposing these patients to a greater risk of injuries. With regard to socioeconomic level, these studies reveal that 69% of the patient participants were in class C of the ABEP scale and 11.1% in class D and E, configuring the lowest socioeconomic level of this population. The number of individuals classified in class C and similar to the one found by Silva of 63.8%. The sample profile can be seen in the study by Santos, in which 83.5% of individuals had income up to 3 minimum salaries. The purchasing power is directly linked to the profession, which in this research was more represented by retirement, 66.7%. These results agrees by Oliveira and Martin. In addition, Ball, in their work on diabetic food, reported that most of their participants had unpaid work, 75.25%, being able to be retired, pensioner, or to be without any income. Individuals with low-paid professions or retirees and pensioners and the low socioeconomic status usually do not have access to health service and preventive measures. In addition, they have difficulties in acquiring the necessary medicines, food, among others, resulting in delayed treatment and aggravation of the health. With regard to use of insulin, it was observed that 63.9% of the patients were insulin treated, reinforcing the finding of survey that classify insulin therapy and the presence of an ulcer prior to the amputation as independent risk factor for this condition. When it comes to ulcers, this study found 80% of its participants with this prior condition, similar to the present by in another study, in which the result was 88%. The presence of this lesion favors the loss of the protective barrier, facilitating the entry of microorganisms and the development of infection conditioning and subsequently amputation. Regarding the time with diabetes, it was seen that 88.1% of the amputation. Regarding the time with diabetes, it was seen that 88% of the amputated patients were diagnosed more than 5 years ago, in line with a study in which 71% of the sample had the diagnosis for that same period, while another revealed in average that time with a syndrome of 12 years. In noteworthy that the time of diagnosis may not correspond with the onset of the disease. The injuries caused by type 2 DM can be present for about 9 to 12 years before diagnosis. In addition, most diabetics are diagnosed only through the onset of complications. This is the quad diabetes self-care questionnaire. Here we have the results and the median and maximum of media. We're going to explain furthermore questions that was important to the study. Regarding the quad, the average of days found in this research for the question, in how many of the last 7 days did you follow a health diet, was 4.25 days, a result similar that found by 8 and Gomides with 5 and 6 in 5.6 days, respectively. This is a great difficulty in following the proper diet is due to numerous reasons. Dissatisfaction with this restrictive nature, the high cost of health foods, in addition to the various meanings that following a diet brings, such as the loss of pleasure in eating and drinking, restriction of autonomy, and the lack of freedom to eat as much as you want, are example of this. According to a survey to assess the eating behavior of diabetic women, there is a great difficulty in following an adequate diet due to numerous reasons. A strict diet brings the loss of the pleasure of eating and drinking, the restriction of autonomy, and the lack of freedom to eat as much as you want, as our example of this. Regarding oral antidiabetic drugs, 88.9% of the patients reported using them. On the question, how many days of the last 7 days did you take your medications for diabetes as recommended, and how many of the last 7 days did you take your insulin injection as recommended, the means obtained was 6.24 days and 6.11 days, respectively. These results were similar to those found by aid of 6.7 days for drugs and 6.9 days for insulin. One study showed that not taking medications correctly is a determining factor for amputation. Proper use of these medications proves to be an important factor in the treatment of diabetes, contributing to better glycemic control, favoring the prevention of diabetic foot. To the question, how many of the last 7 days did you measure your blood sugar? The resulting mean was 4.5 days, similar to the find by Gomides et al. That mean was 5.8 days. Capillary monitoring is one of the paramount importance to direct actions
I think there is some network error. So due to some technical issues, we couldn't, due to some technical errors, we couldn't play the full video of that session. So we can move to the last session of Dr. Nairi Reyes from Mexico. The topic will be acute pancreatitis associated with primary hyperparathyroidism. So after that session, we will conclude, and we would like to have a group picture of everyone after this session. So kindly share the video presentation of that.
Hello everyone, I am Dr. Nayeli Reyes Saavedra from Mexico. First of all, I want to thank Scientex Conferences for the invitation and the opportunity of this space. Today, I am going to present a case that we published in the Internal Medicine Journal, named Acute Pancreatitis Associated with Primary Hyperparathyroidism, a case report. My current assignment is in the Gastroenterology Department in Hospital Español de México, but this article was published during my stay at the General Hospital of Pachuca during my internal medicine residency. I declare that I have no conflict of interest. Acute pancreatitis is the most common gastrointestinal disease that requires hospital admission. Approximately 20% of patients have a moderate severe condition with a mortality of 20 to 40%. Of the multiple etiologies, biliary and alcohol cause 80 to 90% of cases, followed by hypertriglyceridemia, medications, trauma, ischemia, infections, autoimmune diseases, endoscopic retrograde cholangiopancreatography, and hypercalcemia. Hypercalcemia is associated with hyperparathyroidism and malignant neoplasms in 90% of cases. Primary hyperparathyroidism occurs in 0.2 to 0.5% of the population, has a higher incidence between the third and the fifth decade of life, and parathyroid adenoma is the most common cause with 85%. The diagnosis is made with a detection of elevated levels of serum parathormone, and adenomas can be detected in a scintigram with technetium 99 and sestamibi. The treatment is surgical resection with a cure rate of 100%. Hyperparathyroidism and hypercalcemia states are a rare cause of acute pancreatitis, with a prevalence of 1.5 to 7% and a reported incidence of 1.5%. The deposit of calcium salt in the Wilson duct has been proposed, causing the conversion of trypsinogen to trypsin, resulting in autodigestion of pancreatic cells and subsequent local and systemic inflammation. It has been reported that people with this condition have a 10 times greater risk of developing acute pancreatitis. Surgical resection is indicated in symptomatic patients, and parathyroid hormone values normalize after adenoma resection. So we present a woman of 54-year-old that had diabetes type 2 and high blood pressure of 2 years of diagnosis, who takes metformin and losartan as normal medication. With previous surgeries, cholecystectomy at 26 years old, no alcohol nor tobacco consumption, and a biomass exposure index of 100 hours a year. She started her actual illness 5 days before her admission to emergency room with abdominal pain in mesogastrium, transfictive, very intense, 10 of 10, with vomiting of gastric content and fever. At the emergency department, we found her sleepy, In the neck, an increase in size in the right lobe of the thyroid and soft and mobile non-painful bilateral cervical lymph nodes. Pleural effusion. At the abdomen, it was painful at palpation. Peristalsis was decreasing intensity and frequency. And we found her with a heart rate of 85, a respiratory rate of 20, a blood pressure of 128/79, a temperature of 37.5, and an oxygenation of 94 with nasal cannulas at 3 liters per minute. In the laboratory test, we found a lipase over a 1,200, an amylase of 1,216, a calcium value of 11.2. We found also leukocytosis with neutrophilia, acute kidney injury grade 2, and the liver enzymes and bilirubin levels was normal. So we asked in the first option for an ultrasound of the liver and the bile ducts to start the study protocol for pancreatitis. It was reported normal. So then we asked for an abdominal computed axial tomography. In this, they reported an enlarged edematous pancreas with defined edges and without collections, corresponding to a grade B on the scale of Balthasar, as well as we can observe here bilateral kidney stones. So we start the management with IV fluids, thromboprophylaxis, analgesia, metabolic control, and oxygen. Then we start to study the protocol for hypercalcemia. We have a ratio of chlorine and phosphorus of 61, which was suggestive of parathyroid hormone-dependent hypercalcemia. So we asked for a parathyroid hormone and a thyroid ultrasound. The thyroid ultrasound we have here reported an enlargement of the gland with a probably heterogeneous vascularized image dependent in the right inferior parathyroid as well as bilateral positive lymph nodes. The parathyroid hormone level was 123. It was high. The thyroid stimulating hormone was 10.4 and the T4L was 0.69. It was low. So we made the diagnosis of hyperparathyroidism and primary hypothyroidism. So we start the levothyroxine in the hospital. And then we ask for a parathyroid gammagram with sestamibi, which they confirmed the diagnosis of a parathyroid adenoma, which was surgically resected without complications and with preservation of the thyroid gland. We also confirmed the diagnosis. The histopathology report of the resected parathyroid tumor was compatible with a parathyroid adenoma, and postsurgical values of calcium was 9.4 and of parathormone was 41.2. So the patient was discharged from the hospital and continues in follow-up appointments in the gastroenterology, endocrinology, surgery, and urology services and has not had another case of pancreatitis since then. An association between these two entities, acute pancreatitis and hyperparathyroidism, was found since 1903 by Erdheim by observing an event of necrosarian pancreatitis in a patient with parathyroid adenoma. We found approximately 124 similar cases in our review, and since then it has been included as a cause of acute or even chronic pancreatitis. Hypercalcemia as a cause of pancreatitis is reported in less than 1% of patients. Less than 4% of primary hyperparathyroidism develop acute pancreatitis. The majority of events of this etiology occur in women, so it is an important factor when studying a woman with pancreatitis once the first cause, biliary, has been ruled out. In the case of our patient, she had a history of cholecystectomy 28 years ago and no biliary pathology demonstrated by ultrasound. No history of chronic alcohol consumption. She did not have dyslipidemia and the medication she was taking were not relevant. There is evidence of prevention of recurrent pancreatitis in patients who undergo parathyroidectomy, and the only cure option is surgical treatment, which is the treatment of choice in patients who present with bilateral nephrolithiasis or severe hypercalcemia, which our patient had. There are reports of a delay in diagnosis of pancreatitis due to precalcemia with a producer adenoma, being identified in the 4th episode of acute pancreatitis. So as conclusion, patients who present with pancreatitis and the most common causes have been ruled out must undergo a rigorous study protocol. If hypercalcemia is found, a parathyroid adenoma must be intentionally searched. Surgical management could avoid recurrent chronic pancreatitis or complications secondary to the acute event, such as pancreatic insufficiency. Thank you so much.
So with this, we have. So with this, we conclude. I hope everyone has enjoyed a lot and a lot of knowledge we have gained. And definitely the memories we carry from this meeting we will cherish it forever. And to keep the memories, I would like to request everyone to turn on their cameras and say cheese so that we can take group pictures for the future. Can everyone please open their cameras so that we can take a group picture for us? I think Dr. De Silva, you are on mute. You can unmute. So I think everyone is busy. So thank you everyone, and it was a nice experience, and thank you. So here it is night in India, so I would like to say everyone good night, and I wish you a very bright future ahead. Thanks a lot. Bye.
Good evening. My name is Ariadne Beatriz. I'm very honored to be here. Thank you to the committee for the invitation to present my final paper. That is very important to me. Thank you to the other authors of the article, and thank you to the Universidade do Extremo Sul de Santa Catarina, UNESCO, em Criciúma, Brasil. Diabetes mellitus, DM, is defined. Good evening. My name is Ariadne Beatriz. I'm very honored to be here. Diabetes mellitus, DM, is defined as a... Good evening. My name is Ariadne Beatriz. I'm very honored to be here. Thank you to the committee for the invitation to present my final paper. That is very important to me. Thank you to the other authors of the article, and thank you to the Universidade do Extremo Sul de Santa Catarina, UNESCO, in Criciúma, Brazil, that made it possible to carry out this research in the clinic in its dependencies. I'm a doctor. I graduated in 2021 in that university. In UNESCO, there are several areas of activity that aim to interdisciplinary and scientific research. In January of 2023, there were 6,531 consultations in the dependence of these clinics. This article is the result of my final paper in the medical school. I chose this subject because I admire my mentor, Professor Liliane, who is a nurse specialized in diabetes, and because I realized the importance of multidisciplinary work for the best management of these patients. Diabetes mellitus, DM, is defined as a serious chronic disease present when the pancreas does not produce enough insulin or when the body does not correctly use the synthesized insulin, resulting in chronic hyperglycemia. The condition leads to several micro and macrovascular complications affecting the quality of life of individuals, which may lead to a significant reduction of life expectancy. DM is a worldwide problem, with its numbers increasing from 108 million in 1980 to 422 million in 2014. Currently, there are about 425 million people with diabetes in the world, comprising 8.8% of the global population between 20 to 79 years old. Of those, at about 79% live in underdeveloped countries. If this trend continues, it is estimated that by 2045, 6,029 million people will have diabetes. 629 million, sorry. Brazil ranks in fourth in number of diagnoses with 13 million of patients, just behind China, USA, and India. The most common subtype is type 2 diabetes mellitus, DM2, which is 90 to 95% of cases and is generally associated with overweight, sedentary lifestyle, smoking, and a positive family history for DM. DM2 affects mainly adults from the age of 50. However, it has been observed increasing in young people, justified by the current lifestyle. The disease stalls itself insidiously, and the symptoms may take many years to appear, being frequently the diagnosis when complications, acute or chronic, are already present. In order to identify the onset of this complication early, diabetic individuals should be evaluated periodically through clinical and laboratory tests. Chronic complications include retinopathy, nephropathy, heart disease, cerebral vascular disease, neuropathy, and peripheral vascular disease, PVD. The last two added to orthopedics and infection alterations when present in the feet or in the lower limbs of diabetics, individually or in combination, are referred to the diabetic foot, which affects approximately 15% of these individuals. Peripheral neuropathy is the most frequent problem associated with diabetic foot, and it may affect sensory, motor, and autonomic fibers. The impairment of the sensory fiber causes a gradual decrease in protective-sensitive and its perception of blood pressure, temperature, and proprioception of the food. The damaged autonomic component generates a reduction of food sweating, leaving them dry and susceptible to the development of injuries. Alteration in the motor part of the nerves lead to atrophy and dorsal muscle generation, osteoarticular deformity, and maladjustment in walking. Diabetes food complications are a common cause of admission of diabetes to hospital, and they are the main determinant of quality of life for these patients. Ulcers are the most prevalent consequence, with an annual incidence of 2 to 10% in developed countries. The lifetime risk of an individual with DM to develop ulcers exceeds 25%, and they can become serious with gangrene and infection, and due to the underlying disease itself, the healing of these lesions is usually compromised, ultimately requiring local amputation. About 40 to 60% of non-traumatic lower limb amputation are caused by DM, and of these 85% are preceded by ulcers. The number of amputations in diabetes is 10 to 20 times higher compared to the population without the disease. In terms of mortality, approximately 10% of the patients who amputate the lower limb die in the preoperative period. 30% die in the first year post-amputation, and 50% in third year, and 70% in the fifth year. To determine the prevalence, the object of this work is to determine the prevalence and risk factors associated with amputation to DM, focusing on aspects related to basic care, self-care, and socioeconomic profile. The present study presents a quality and quantitative approach of a cross-section and descriptive nature, seeking to understand the risk factor and the prevalence of amputation in patients with DM. The research took place in an integrated clinic of a university in southern Brazil during the periods from March to August of 2019. The sample was randomly composed of 42 patients with lower limb amputations who were assisted by university clinic, and of these 36 have diabetes mellitus as the cause of amputation, forming the final sample. The remaining 6 patients entered the study by way of prevalence analysis. As exclusion criteria for the sample, patients should be over 18 years old and present some amputation in the lower limbs. The data collected was organized and analyzed by using the IBM statistical package for the social service science version 22.0, was divided in The data collected was organized and analyzed by using the IBM statistical package The importance of identifying risk factor is related to the prevention of both the first amputation and future ones, since 30 to 50% of patients who need an amputation will require additional amputations in 1 to 3 years. The prevalence of amputations due to diabetes mellitus observed in this study was 85.7%, a rate similar to the obtained by Martins of 88.6%. Regarding the age range, the average age found in the survey was 63.17 years old, equivalent to the result of work by Gomez. That average was 60 years old, respectively. Santos et al. Found in their study that 61.2% of the sample were in the 60th decade of life or more. In several studies, age above 60 years old has shown a risk factor linked to the installation of diabetic foods and subsequent amputation. The natural aging process implies a gradual and progressive decrease in the functional capacity that, when associated with other factors such as diabetes itself and lower education, can result in the development of complications, especially due to the difficulty in its self-care. In terms of gender, 75% of the sample consisted of males, similar to result found by Alverson. According to a research carried out with the object of investigating the difference in self-care with the fit and in lifestyle between women and men with diabetes, men present worse results, lower frequency of drying between the toes, non-periodic evaluations of the feet, habit of walking barefoot, unsatisfactory hygiene, and inadequate nail cutting. In addition to higher rate of smoking, alcohol intake above the recommended level, deficit in dietary control, and lower frequency of laboratory tests were the results observed. Low schooling was imperative in this research, with 72.2% of respondents completed only elementary school, a fact consistent with some studies observed. Regarding to diabetic foods, bowel presents the percentage of 72.85% of its participants completed only elementary school. The level of education influences adherence to treatment, enabling better glycemic control and consequently the prevention of complications. Poor schooling makes this teaching and learning process difficult, which is a fundamental step in education diabetics to develop self-care skill with their feet, exposing these patients to a greater risk of injuries. With regard to socioeconomic level, these studies revealed that 69% of the patient participants were in class C of the ABEP scale and 11.1% in class D and E, configuring the lowest socioeconomic level of this population. The number of individuals classified in class C and similar to the one found by Silva of 63.8%. The sample profile can be seen in the study by Santos, in which 83.5% of individuals had income up to 3 minimum salaries. The purchasing power is directly linked to the profession, which in this research was more represented by retirement, 66.7%. These results agree by Oliveira and Martin. In addition, Ball, in their work on diabetic food, reported that most of their participants had unpaid work, 75.25%, being able to be retired, pensioner, or to be without any income. Individuals with low-paid professions or retirees and pensioners and the low socioeconomic status usually do not have access to health service and preventive measures. In addition, they have difficulties in acquiring the necessary medicines, food, among others, resulting in delayed treatment and aggravation of the health. With regard to use of insulin, it was observed that 63.9% of the patients were insulin treated, reinforcing the finding of survey that classify insulin therapy and the presence of an ulcer prior to the amputation as independent risk factor for this condition. When it comes to ulcers, this study found 80% of its participants with this prior condition, similar to the present by in another study, in which the result was 88%. The presence of this lesion favors the loss of the protective barrier, facilitating the entry of microorganisms and the development of infection conditioning and subsequent amputation. Regarding the time with diabetes, it was seen that 88.1% of the amputation. Regarding the time with diabetes, it was seen that 88% of the amputated patients were diagnosed more than 5 years ago, in line with a study in which 71% of the sample had the diagnosis for that same period, while another revealed in average that time with a syndrome of 12 years. In noteworthy that the time of diagnosis may not correspond with the onset of the disease. The injuries caused by type 2 DM can be present for about 9 to 12 years before diagnosis. In addition, most diabetics are diagnosed only through the onset of complications. This is the quad diabetes self-care questionnaire. Here we have the results and the median and maximum of media. We're going to explain furthermore questions that was important to the study. Regarding the quad, the average of days found in this research for the question, in how many of the last 7 days did you follow a health diet, was 4.25 days, a result similar that found by 8 and Gomides with 5 and 6 in 5.6 days, respectively. This has a great difficulty in following the proper diet is due to numerous reasons. Dissatisfaction with this restrictive nature, the high cost of health foods, in addition to the various meanings that following a diet brings, such as the loss of pleasure in eating and drinking, restriction of autonomy, and the lack of freedom to eat as much as you want, are example of this. According to a survey to assess the eating behavior of diabetic women, there is a great difficulty in following an adequate diet due to numerous reasons. A strict diet brings the loss of the pleasure of eating and drinking, the restriction of autonomy, and the lack of freedom to eat as much as you want, as our example of this. Regarding oral antidiabetic drugs, 88.9% of the patients reported using them. On the question, how many days of the last 7 days did you take your medications for diabetes as recommended, and how many of the last 7 days did you take your insulin injection as recommended, the means obtained was 6.24 days and 6.11 days, respectively. These results were similar to those found by aid of 6.7 days for drugs and 6.9 days for insulin. One study showed that not taking medications correctly is a determining factor for amputation. Proper use of these medications proves to be an important factor in the treatment of diabetes, contributing to better glycemic control, favoring the prevention of diabetic foot.
Hello everyone, I am Dr. Nayeri Reyes Saavedra from Mexico. First of all, I want to thank Scientex Conferences for the invitation and the opportunity of this space. Today, I am going to present a case that we published in the Internal Medicine Journal, named Acute Pancreatitis Associated with Primary Hyperparathyroidism, a case report. My current assignment is in the gastroenterology department in Hospital Español de Mexico, but this article was published during my stay at the General Hospital of Pachuca during my internal medicine residency. I declare that I have no conflict of interest. Acute pancreatitis is the most common gastrointestinal disease that requires hospital admission. Approximately 20% of patients have a moderate severe condition with a mortality of 20 to 40%. Of the multiple etiologies, biliary and alcohol cause 80 to 90% of cases, followed by hypertriglyceridemia, medications, trauma, ischemia, infections, autoimmune diseases, endoscopic retrograde cholangiopancreatography, and hypercalcemia. Hypercalcemia is associated with hyperparathyroidism and malignant neoplasms in 90% of cases. Primary hyperparathyroidism occurs in 0.2 to 0.5% of the population, has a higher incidence between the third and the fifth decade of life, and parathyroid adenoma is the most common cause with 85%. The diagnosis is made with a detection of elevated levels of serum parathormone, and adenomas can be detected in a scintigram with technetium 99 and sestamibi. The treatment is surgical resection with a cure rate of 100%. Hyperparathyroidism and hypercalcemia states are a rare cause of acute pancreatitis, with a prevalence of 1.5 to 7% and a reported incidence of 1.5%. The deposit of calcium salt in the Wilson duct has been proposed, causing the conversion of trypsinogen to trypsin, resulting in autodigestion of pancreatic cells and subsequent local and systemic inflammation. It has been reported that people with this condition have a 10 times greater risk of developing acute pancreatitis. Surgical resection is indicated in symptomatic patients and parathyroid hormone values normalize after adenoma resection. So we present a woman of 54-year-old that had diabetes type 2 and high blood pressure of 2 years of diagnosis, who takes metformin and losartan as normal medication. With previous surgeries, cholecystectomy at 26 years old, no alcohol nor tobacco consumption, and a biomass exposure index of 100 hours a year. She started her actual illness 5 days before her admission to emergency room with abdominal pain in mesogastrium, transfictive, very intense, 10 of 10, with vomiting of gastric content and fever. At the emergency department, we found her sleepy, in the neck, an increase in size in the right lobe of the thyroid, and soft and mobile non-painful bilateral cervical lymph nodes. Pleural effusion. At the abdomen, it was painful at palpation, peristalsis was decreasing intensity and frequency. And we found her with a heart rate of 85, a respiratory rate of 20, a blood pressure of 128/79, a temperature of 37.5, and an oxygenation of 94 with nasal cannulas at 3 liters per minute. In the laboratory test, we found a lipase over a 1,200, an amylase of 1,216, a calcium value of 11.2. We found also leukocytosis with neutrophilia, acute kidney injury grade 2, and the liver enzymes and bilirubin levels was normal. So we asked in the first option for an ultrasound of the liver and the bile ducts to start the study protocol for pancreatitis. It was reported normal. So then we asked for an abdominal computed axial tomography. In this, they reported an enlarged edematous pancreas with defined edges and without collections, corresponding to a grade B on the scale of Balthasar, as well as we can observe here bilateral kidney stones. So we start the management with IV fluids, thromboprophylaxis, analgesia, metabolic control, and oxygen. Then we start to study the protocol for hypercalcemia. We have a ratio of chlorine and phosphorus of 61, which was suggestive of parathyroid hormone-dependent hypercalcemia. So we asked for a parathyroid hormone and a thyroid ultrasound. The thyroid ultrasound we have here reported an enlargement of the gland with a probably heterogeneous vascularized image dependent in the right inferior parathyroid as well as bilateral positive lymph nodes. The parathyroid hormone level was 123. It was high. The thyroid stimulating hormone was 10.4 and the T4L was 0.69. It was low. So we made the diagnosis of hyperparathyroidism and primary hypothyroidism. So we start the levothyroxine in the hospital. And then we ask for a parathyroid gammagram with sestamibi, which they confirmed the diagnosis of a parathyroid adenoma, which was surgically resected without complications and with preservation of the thyroid gland. We also confirmed the diagnosis. The histopathology report of the resected parathyroid tumor was compatible with a parathyroid adenoma, and post-surgical values of calcium was 9.4 and of parathormone was 41.2. So the patient was discharged from the hospital and continues in follow-up appointments in the gastroenterology, endocrinology, surgery, and urology services and has not had another case of pancreatitis since then. An association between these two entities, acute pancreatitis and hyperparathyroidism, was found since 1903 by Erdheim by observing an event of necrosizing pancreatitis in a patient with parathyroid adenoma. We found approximately 124 similar cases in our review, and since then it has been included as a cause of acute or even chronic pancreatitis. Hypercalcemia as a cause of pancreatitis is reported in less than 1% of patients. Less than 4% of primary hyperparathyroidism develop acute pancreatitis. The majority of events of this etiology occur in women, so it is an important factor when studying a woman with pancreatitis once the first cause, biliary, has been ruled out. In the case of our patient, she had a history of cholecystectomy 28 years ago and no biliary pathology demonstrated by ultrasound. No history of chronic alcohol consumption. She did not have dyslipidemia and the medication she was taking were not relevant. There is evidence of prevention of recurrent pancreatitis in patients who undergo parathyroidectomy, and the only cure option is surgical treatment, which is the treatment of choice in patients who present with bilateral nephrolithiasis or severe hypercalcemia, which our patient had. There are reports of a delay in diagnosis of pancreatitis due to precalcemia with a producer adenoma, being identified in the 4th episode of acute pancreatitis. So as conclusion, patients who present with pancreatitis and the most common causes have been ruled out must undergo a rigorous study protocol. If hypercalcemia is found, a parathyroid adenoma must be intentionally searched. Surgical management could avoid recurrent chronic pancreatitis or complications secondary to the acute event, such as pancreatic insufficiency.